So, as we were discussing the storage of the vaccine, and we know that this is a very important instrument, that is ILR. And ILR is ice lined refrigerator. It is lined with the ice and it is designed in such a way that electric supply of minimum 8 hours is sufficient to store the vaccine till 24 hours, keeping a temperature of +2 to +8 degree centigrade. And here the vaccines are arranged in a systematic order. The mainly that OPV and the measles vaccine, which are very heat sensitive, they are usually kept at the bottom of this ILR, and the vaccine, the hepatitis B and the TT-DPT vaccine, they are kept over the top because they are less heat sensitive vaccines. And very important point is that the temperature, that is +2 to +80 degrees centigrade, what we are keeping in the ILR is checked by the thermometer, that is a dial thermometer, and it is used to record the temperature of an ILR twice a day we are recording. And these are the vaccine carrier boxes, and they are used to take the vaccines from the primary health centers to the sub centers and the village where the vaccination is given in the periphery. And these are having the 4 ice packs, and they can hold up to the 16 to 20 vials. And if you see the detailed view of these ice packs are having the holes, and these holes are to hold the vaccine during the vaccination session. So the important points about the storage is that the cold chain temperature is +2 to +8 degrees centigrade. There is a reverse cold chain, means it is not the transferring back of the vaccines from the periphery to the manufacturing unit, but it is the transfer of the stool sample of the suspected polio case to the laboratory, as the polio virus is a royal virus transferred in a royal condition, and that condition is +2 to +8 degrees centigrade. Then we are storing all the vaccines in the PSC in ILR, that is the heart of the cold chain, including the measles as well as the OPV vaccine. But if we have to store for a longer time from the district hospital onwards, like 3 months, then we are keeping the measles vaccine and the oral polio vaccine in the freezer component, and rest of the vaccines we are keeping in the the lower compartment. Okay, then maximum duration of the storage at the primary health center is about 1 month. Then always remember the vitamin A is stored at the room temperature. And the maximum chances of the cold chain failure happens while the vaccine is being transferred to the sub-center and the village. Then the most heat sensitive vaccine is the oral polio vaccine, followed by the measles and the BCG. And if we say that the comparison between the OPV or the reconstituted BCG, then reconstituted BCG is more heat sensitive. The most heat sensitive vaccine is the hepatitis B, followed by TT or the DPT. Means if they are kept accidentally in the freezer component, then they are getting destroyed. And these are the vaccine vial monitors. So vaccine vial monitor, it is a sticker which is kept on the vaccine to check for its damage by the heat. And we are having the 4 stages of the 4 grades. In the grade 1, that is the white color, outer one is a light blue color. It can be used the grade 2, it is having a color lighter than the outer one, the inner square. The grade 3, it is having the same color as an outer one. The grade 4 is the darker one. So grade 3 and grade 4 are not used, and if the vaccine vial monitor is in a stage of grade 1 and grade 2, yes, we can use. Now how we can check for the freeze damage of the vaccine? The freeze damage is checked by the shake test. Means we are testing the vial, which we are supposing that it has been damaged by the low temperature, and we are keeping a one vaccine of the same batch in the freezer overnight, and then we are shaking both the vials and keeping for some time, and we look for the settlement or the sedimentation. Now if the vial vaccine is turbid uniform and it is not getting settled down, it means it is not damaged by the low temperature. But if it is settling down and we are forming the sedimentation at the base of the vial, or the rate of sedimentation, it is faster than the control one or at the same rate, and then this vial has been damaged because of the low temperature and we have to discard. Okay, so this is the shake test what we are using to check for the freeze damage of the vaccine. Then A very important program we are having is the Mission Indradhanush. Now, Mission Indradhanush, this is the logo of the national program. Now, here the point what we have to remember in the Mission Indradhanush is that this was started in December 2014, and the goal was to vaccinate up to the 90% of the children of the 1 year of the age for seven killer diseases by December 2020. And these seven diseases were the tuberculosis, the polio, hepatitis B, diphtheria, pertussis, tetanus, and the measles. And we were doing this survey in the age group of the 12 to 13 months by the cluster random sampling, and that is 13 to 7 clusters we were having, and in each cluster we are having the seven children, and 30 clusters we were taking. And this was to check for those children who are left out with the doses of the vaccine, that we were giving them the left out doses. Then government has decided that why we have to wait for 2020, we have to prepone our goal, and then came the intensified mission in Dhanush. It was launched in the month of October 8th on 2017, and our goal was that we have to vaccinate around 800% children, or more than 90% of the children, by December 2018 for 1 year of the child, not for the seven diseases, but certain diseases were added. And the added vaccines were the rotavirus, Hib vaccine, injectable polio vaccine, pneumococcal vaccine, Japanese encephalitis, vitamin A, and the rubella. And we say that if by the age of 1 year the child had received the desired doses of the vaccine, the child is having the complete immunization. And by the 2 year, if the child is having the desired doses of the vaccine, that we say the child is fully immunized or fully vaccinated. Then very important is the open vial policy. The open vial policy means if you are opening a multi-dose vial, within how much time we have to use. So open vial policy says that after opening a multi-dose vial, it should be used within 28 days. And this is applicable on the TT vial, TD vial, DPT vial, hepatitis B vial, pentavalent pneumococcal OPV, and the injectable polio vaccine. But remember, it is not applicable for the BCG, measles, MMR, Japanese encephalitis, or the rotavirus vaccine, because in the BCG, measles, MMR, and the Japanese encephalitis, they are available in the powder form, and once we have to dissolve them, and as we had already discussed, that we have to use within the next 4 hours, so we cannot leave beyond that. Then the point is that what is a ring immunization? Ring immunization means that if we had a suspicion of a infected case, that within 100 meter, or sorry, within 100 yard radius of the infected case, we have to vaccinate the susceptible children, and this will help us in preventing the spread of an infection and preventing the development of upcoming epidemic. So this is your ring immunization. And what we mean by the herd immunization, herd means a vaccination of a group of individuals. So if we are vaccinating our community beyond a certain percentage, then it is breaking the chain of transmission. So the herd immunity means that we have to break the chain of transmission from that point, and it depends upon the infectivity of the disease. Highly infectious the disease, the more percentage of the individuals are required to break this chain of transmission. And as we say that for the measles, pertussis, chickenpox, highly infectious, so the threshold of herd immunity is more than 90%. So we have to vaccinate more than 90% individuals, then only we can break this chain of transmission. While in polio and the mumps, it is up to 80 to 85%. And as we all know that tetanus and the rabies, they are not transmitted from one to another, so there is no role of herd immunity. So these were the few important points about the vaccines. Then next is the concept of health and disease. As we all know that WHO says that the state of complete physical, mental, and the social well-being is the health, not only the absence of the disease. Now, very importantly, ask is the what are the indicators of quality of a life. Now we have to remember the two important indicators, the physical quality of the life index and human developmental index. And very commonly they ask what are the parameters included. As we always remember the difficult points with the mnemonic, and the mnemonic we had made for this is the bigger a letter a word is PQLI, the 4 a letter word, and the bigger word. So we are having the life expectancy at the bigger age. So life expectancy starts here at a 1 year of the age. Obviously, it is including the infant mortality rate, that is a mortality in the first 1 year, as well as it is including the literacy rate. While in the HDI, it is a three-letter word, small letter word. So we are having the life expectancy at a smaller age at the birth, and we are including the income also, because income or high income, or the money if a family is having, is able to avail the services better and could be the better quality of the life. And the knowledge is the replacement of the literacy. And now the knowledge is further divided into the two groups: the mean years of the schooling and expected years of the schooling. But remember one point: sometimes they don't write the knowledge in the HDI, they write a literacy rate also. So we may consider that if other parameters are more important. Okay, then same like the life expectancy, sometimes they write as a longevity. So it is same as life expectancy. So read the question very carefully and you have to answer accordingly. Then another point is the range. The range is 0 to 100 in the PQLI, bigger letter word, the bigger range, 0 to 1, smaller range in the SDI. Now here I'll just put on a one more range, and that is for the correlation coefficient. We will discuss in the statistic that it is between the minus a 1 to plus a 1. So these are the three ranges what we have to remember. The PQLI is 0 to 100, the HDI it is 0 to 1, and the correlation coefficient is the minus 1 to plus a 1. Then if we talk about the value of these parameters, then HDI is used for the international comparison, and for the calculation for the PQLR we are having the arithmetic mean, and for the HDI we are having the geometric mean. So we have to calculate the indexes separately, and then we are taking the geometric mean for calculation of HDI. Then we are having the various indicators of health, and the important for the exams are the various mortality indicators and the disability indicators. Now here we have to remember the definitions, that what is a numerator, what is a denominator, what is the multiplying factor. The crude death rate is the number of the death in the given time per thousand mid-year population, and the mid-year is the population on the 1st of July. Then we can have the infant mortality rate, number of the infant deaths. Infant is a less than 1 year old child per 1000 live births. Very important. And this infant mortality rate is a very important indicator of the health status of our country. Now, very, very important is the maternal mortality. It is not a rate, it is a ratio. So, maternal mortality ratio, it is the number of the maternal death per 1 lakh live births. So, this is again very important. The multiplying factor is the 1 lakh, not the 1000 or not the 100, and the denominator is the total live births, not the total pregnancies. So actually this is a ratio comparing the maternal deaths to the live births. Clear? And this is a important indicator of the availability and the utilization of the maternal services under the MCH care. And the positive mortality indicator is life expectancy. Then we are having the various disability indicators, and important are the QALY, DALY, and the HALY. Now, QALY is the quality adjusted life years, the life lived in the good quality of the health with the adjustment. Now, the DALY is the disability adjusted life years, the life lived with the disability, or the years lost prematurely is the DALY. Or we can have the disability free life expectancy. Now, how we are expecting the years which is expected to live in a healthy state is the disability free life expectancy. But if it is with the adjustment, then it becomes the HALY, that is health adjusted life expectancy. So years expected to live in a healthy state with adjustment. So in future what we are expecting to live without adjustment is the disability free life expectancy, with adjustment is the HALY, and the life which is already lived with adjustment is the QALY, and live with the disability is the DALY. Okay, so HALY, it is supposed to be the best indicator of the disability, and the DALY is supposed to be the best indicator of the burden of the disease, and one DALY is as the 1 year lost. And we are having the other indicators of the burden of the disease as the prevalence of the disease and the proportional mortality rate. Now, proportional means it is a proportion of the total deaths to death actually happened because of the particular reason. So the PMR, or the proportional mortality rate of a single disease, is equal to the total deaths because of that specific disease per 100 total deaths because of the all causes. Then we know that time to time the various theories has been given, as the superstitious theory by Aristotle, then infectious theory or the infective theory by the Louis Pasteur, the Patton-Koffer has given the multifactorial theory, the McMahon and Pugh has given a web of position theory, but most accepted is the epidemiological theory by John Snow, who is considered as father of modern epidemiology also, and he had given the epidemiological triad as the agent, host, and environment. And when the time was added, it became epidemiological tetrad, that is the agent, host, environment, and time. But later on, the agent was replaced by the causative factors, and we don't have a specific host. We are having the population or the community. We had a multiple environmental factors also. So now we have come up with the advanced model of an epidemiological tetrad, where the agent is replaced by the causative factors, the host is by the community or the society, and the environment is by physical, genetic, socioeconomic, psychological, or the nutritional environment. Okay. Now we are having the iceberg phenomena. Iceberg phenomena means the some diseases they show like that the cases subclinical and the carrier cases they are hidden inside the society, and these are comprising up to the 90% of those disease cases, and only the 10% cases or the individuals they are showing the symptoms and they are coming to the clinical centers for their diagnosis and the treatment. So here the point is that who is representing the tip? The tip is by the clinical cases. The submerged water is representing the subclinical cases, carriers, or the undiagnosed cases, which is most dangerous section. And the demarcation line is the water line, which is the demarcation between the visible or the apparent cases or the hidden cases, and the surrounding water is the healthy population. And here the question is that what are the diseases showing the iceberg phenomena? What are the diseases not showing the iceberg phenomena? So remember that in a disease cycle, if we had a subclinical cases and the carriers, definitely they will show the iceberg phenomena. And where we don't have the subclinical cases and the carrier cases, they will not show the phenomena. So like the rabies, measles, and the tetanus, they are not showing the iceberg phenomena, while the HIV, COVID-19, hepatitis B, typhoid, cholera, meningococcal meningitis, so other diseases, they are showing the iceberg phenomena. Then we are having the surveillance activity. Surveillance means we are collecting the information, taking an action, and this surveillance can be the active, passive, or sentinel surveillance. Active means the health worker is going to house of the patient, means they are going directly to their houses and they are trying to do the examination and trying to find out the suspicious cases. And very commonly they ask that what workers are responsible for the active surveillance of what diseases. So the multi-purpose worker male, very very important question. It is responsible for the active malaria surveillance, visiting house to house, preparing the slides for examination. While the ASHA worker, it is responsible for the active surveillance of the tuberculosis, leprosy, filariasis, and leishmaniasis. In the passive surveillance, the suspected individual who is having the symptoms are going to the health centers for the diagnosis and the treatment, as we are doing the passive surveillance for HIV, cancer, hypertension, or diabetes mellitus, or non-communicable diseases. The very important is the sentinel surveillance. Sentinel surveillance is that from the one case that we are trying to identify the other hidden cases in the society, so we have to supplement more the notified cases, and this is used in the case of the sexually transmitted infections as well as in the current pandemic of the COVID infection. We are using the sentinel surveillance to identify the COVID cases in the family or in the nearby contact. Then if a disease is not being treated, it can lead to the impairment, disability, or handicap. So we have to remember the sequence. Or if we are managing a disease, we can have either the control or elimination or eradication. Now, eradication is the ultimate. Ultimate means that we are removing the agent also from the environment. And till today, we had only eradicated the single disease, that is the smallpox. It was eradicated a declaration by the WHO on the 8th of May 1980, but we had eradicated the two more viruses. that is the P2 in 2015 and the P3 in 2019. But still, we don't say that we had eradicated the polio, because still we are left with the P1 virus. And the diseases which we are planning to have an eradication in near future is the measles and polio. So we cannot set the timeline because it is through the globe. Then if we are breaking this chain of transmission, so we are not having any new case, but still the agent is persisting, then that is the elimination. So very, very important point is that even if we have eliminated a particular disease, we have to continue our surveillance activity, what is stopped in eradication. Because in elimination, the agent is in the environment, so there is a possibility of recurrence of that particular disease. So we have to continue our surveillance activity. Like India has eliminated polio, but still we are giving the polio vaccination to our children to avoid the recurrence of this infection. So, India had eliminated the diseases as the leprosy, yaws, polio, neonatal tetanus, tuberculosis, and still we are waiting for the trachoma elimination certification. And the diseases what we are planning to do elimination in the near future, the filariasis and leishmaniasis by 2020, and tuberculosis by 2025, malaria is by 2030. So these are our goals for elimination. But remember one point, that goal is not time bound. So if you are not able to achieve our goal by this time, we can extend our goal. But always remember, for your examination, you have to set the mission. Mission means that, like we had an army mission, that within a given time, at any cost, we have to complete our end point. Otherwise, our mission is abolished and we have to restart all the preparations or all the activities. Okay. So this is about your elimination and eradication. And the death certificate, we are writing in a proper way with the 4 lines. And the most important line is the line 1C, which is telling us the main underlying cause of the death. And the line 2, it is telling the presence of other associated diseases, but they are not contributing to the death at this moment. Then we are having the international classification of the disease. That 11th revision is with us, and it is arranged in 3 volumes, and it is having 26 chapters with alphanumerical classification. Okay, so this was all about your concept of health and disease. Then we had another very important topic, and it is epidemiology. And here the many questions has been asked. So epidemiology, what we have to remember is the father of the modern epidemiology is John Snow, and who had studied the cholera, and after this study the concept of public health appeared. That's why the father of public health is none other than the cholera disease itself. And the study what John Snow has conducted was a case control study, and here he had used the spot map analysis as a data presentation method. Okay. Then we are having the 3 components of epidemiology as frequency, distribution, and the determinants. Now, frequency we'll discuss in terms of incidence and the prevalence of the disease, the distribution in terms of the time, place, and person, and the most important is the time. Many questions has been asked from this section. And the determinants means what is exactly the cause, by combining all this information of the frequency and the distribution, and we have to frame an hypothesis. Okay, and we have to test this hypothesis by the various epidemiological studies. So the frequency is by the incidence and the prevalence, and the 2 important points has been asked. The new cases in a defined period is the incidence, and the total cases of a particular point mainly, or it could be during that particular defined period, is the prevalence. But an important point is that incidence is a rate. It is expressed as per 1,000, while the prevalence is a proportion which is expressed as per 100. So no confusion between the rate, ratio, and the proportion. So if a numerator is a part of denominator, and if it is being expressed as 1,000, it becomes your rate, and if it is expressed as per 100, it becomes your proportion. But if a numerator is not a part of denominator, we are comparing the 2 separate things, then it becomes your ratio. Clear? Then important point is by which study we are calculating. The incidence is calculated by the cohort study. That's why it is also known as incidence study. So in many questions, you can get a hint because they give you a scenario and they ask you to identify the study. And if you're not able to understand, but if they say that they are calculating the incidence, then this study is none other than the cohort study. Same like the parameter calculated by the cross-sectional study is the prevalence. So if they give you a hint that they are calculating the prevalence, then this is your cross-sectional study, or this is also known as prevalence study. And duration, it is not affecting the incidence, but yes, affecting the prevalence. Because shorter is the duration of the disease, then definitely the prevalence will be less. The longer is the duration of the disease, then definitely the prevalence will be more. Then we are having the distribution, and the most important is the time distribution, and we are mainly concerned with the epidemic. Because if the cases are happening in excess of the normal expectancy, and the normal expectancy is up to the mean plus 2 standard deviation. So if the cases are beyond that, we call as an epidemic. If the cases are within this normal expectancy, we say it's an endemic. And if the epidemic is happening in more than one country at a time, it is becoming pandemic. What world is facing a pandemic for COVID-19 for past almost 2 years. It's going to be 2 years. Then we are having the various type of the epidemics, how much time it is taking to become an epidemic, can be the short term, periodic, or the long term. Now, short term epidemic or the short term fluctuations can be because of the common source single exposure or the point source, and examples are the food poisoning, the Bhopal gas tragedy, or the Vizag gas leak. Or we can have the common source multiple exposure. The source is common, but repeatedly the individuals are coming to that source getting an infection. So this is either the HIV transmission or any STD transmission from the sex worker. Sex worker is fixed at a one point. The clients are coming getting an infection, or the water intake from an infected well. But suppose if the person who is becoming infected now is becoming a source and again transmitting the infection to others, then again they are becoming a source transmitting the infection, then this becomes a propagative cycle. Okay, so propagative cycle, the transmission of the sexually transmitted diseases or the waterborne diseases. So it is propagative. So no confusion between the common source multiple exposure. They are coming back to the same source multiple times, that is a common source multiple exposure. But in the propagative, the every infected person becomes a new source and it is transmitting the infection to others. Clear? Then in the periodic, that we are having the epidemic after a certain period, and this can be either because of the seasonal variation, as we could see that in seasonal variation there is a change in the agent, host, or environment and favoring the condition, and can have an epidemic like malaria. It is in the rainy season because of the mosquito breeding, or we can have the measles in the winters because of the overcrowding. Or it can be cyclical. After a certain time the cases are getting more, and this is in cases of influenza. Every year we are having a change in the antigen, and this is leading to the new strain and epidemic. And that's why we are giving the influenza vaccine every year. Now, if you're not continuously vaccinating, then definitely the percentage of the vaccinated individuals, it drops. It is leading to reduction in the herd immune percentage, and it is causing the spread of the disease. And this pattern was seen in the measles, where we are having the epidemic every 2 to 3 years because we were not giving the round the clock vaccination to a newborn babies. But now, as we are giving the vaccination to each and every baby, so now this is not seen currently with the measles. Or change in the human behavior, as we could see the road traffic accidents in the weekends. Now, long-term fluctuation of the epidemic, it is also known as a secular trend. Remember this word, this is commonly asked when there is a continuous change in the one direction over the decades. Now, important are the epidemiological studies. Now, it can be the observational studies or experimental studies. Now, observational can be the descriptive, when we are forming an hypothesis by the taking in consideration the distribution as per the time, place, and person. Then in the analytical studies, we are testing this hypothesis by the various studies, and in the order of their importance is the cohort, case control, cross-sectional, or the ecological studies, while in experimental we are having the hypothesis confirmation. Experimental can be the random studies or non-random. Obviously, the random are better over the non-random studies. Now, very important is that how we can compare the different analytical studies, or what are the important points of differentiation. So if we talk about the direction of the study, so direction in the cohort study, it is the forward direction starting from today, and we are looking for the results later on. So direction is forward in the cohort while already the disease is happening. We are taking history going back. So it is the backward in the case control, and in the ecological and the cross section, we are studying at that particular point only. Now, in whom we are doing this study, it is a population in the ecological, while in the case control cohort and cross sectional, we are doing on an individual person. Now, if we talk about the outcome, means the results what we are expecting. Outcome, it is absent in the cohort, while in rest of the three it is present. And very important is the parameters which are calculated, because that can be a direct straightforward question, that what parameters are calculated by which study. They can be a hint in the given question that identify the study. If they are talking about the one parameter, they can ask you the formula for these parameters also. They can give you a small numerical to calculate these parameters also. So very, very important point. So parameter calculated by the cohort study is the incidence, relative risk, attributable and population attributable risk. By the case control study, it is the odds ratio. By cross-sectional study, it is the prevalence. And by the ecological, we are calculating or deciding the population characteristics. Now, as we know that in the case control study, how we are framing a study, and we are framing a study like that in the beginning we are having the cases, that is forming our one group, and the second group is the control group, and we have to do the matching between the known parameters, which are the known confounders, to avoid the confounding errors. Okay, and then we are going back, and we are looking for the history of the risk factors. So this is the study design going backward from the cases and the control group, looking for the history of the risk factor. Because sometimes they ask a question like this, like in the last if in the exam the question was asked like this, that if you want to conduct a case control study to know the effect of food habits on the obesity, so what groups you will meet. So already we have to conduct a case control study. So one group will of a obese person, second group will be of a healthy person, and then we will ask a history of the food habits, that how much many times they are taking the food, what type of the food they are having, at what type, means junk food they are taking, or that they are taking a homemade food, at what time they are taking. So this will all will be deciding the obesity. So like that, so we have to make a group of the cases and the healthy group or the control, and then we have to go backward to look for the history of risk factor. While opposite we are doing in the cohort study, or this is also known as a prospective study. Clear? And so case control study is also known as a backward study, while the cohort study, it is also known as a prospective study or the forward study. Okay, so here we are starting a study, and we are taking the healthy individuals in both the groups. But in one group, that is an exposed group, we are exposing them to the risk factor, what we presume might be causing the disease. While in the second group, healthy, but they are non-exposed. Again, we have to do the matching between the known parameters to avoid the confounding errors. And then we will wait for some time, and then we'll look for that whether the disease is developing or not. So this is your forward study on the prospective cohort study or the prospective study. But here, if we want to combine the advantages of the case control and the prospective cohort study, because in the prospective cohort, the main advantage is we can calculate the incidence. But the disadvantage is that we have to wait for a very long time. We're exposing our healthy person, and we know that they can develop the disease. We have to waste our money also. Then money here, then we have to waste our time here, manpower. So these are the all disadvantages. So what we do, that in the study that we call as a retrospective cohort, and it is a combination of the case control and the cohort, prospective cohort, and we are taking the advantages of both. So what we do, that we start a study at the point where already the results are with us. So if we are conducting the simple case control, then we will go back and we'll ask for the risk factor. Then this is a simple case control. So, but what we do in this condition, or in this study, retrospective cohort study, we are going back to that point. At that point, they are healthy. So how we can get that point, that at that point they all are healthy. So we might be collecting the hospital records of the individuals who were admitting for some other conditions, and we are taking their personal history. We are having their addresses, so we can collect from that point that they are healthy. And then we are coming forward, analyzing their any medical records, reaching to the today point where some of them had already developed that disease. So here we are starting a disease or the study at a point where already the disease is there. So we are not going to wait for some time, not going in future. And we are coming in a forward direction, so we can calculate the incidence and other parameters, relative risk, attributable risk. So here we are having all the advantages of the case control and the cohort study. So this is your retrospective cohort. So please, if the simple question is asked that what is a retrospective study, so retrospective means backward study, then this is your case control study. But if they say what is the retrospective cohort study, it means you are going little bit back and coming forward. जैसे कहते हैं ना कि अगर आपको लंबी कूद लेनी है, लंबा जंप लेना है, लॉन्ग जंप करना है, so you have to go a few steps back and then you have to come forward, like that. So if you have to get a better study, then you have to go a little bit back and then you have to come forward. That is the retrospective cohort. So if a simple retrospective word is, it means it is a backward study, case control study. But if they say it is a retrospective cohort study, it means it is going back and then coming forward. If they simply say the cohort study, means it is a typical cohort, the forward study or the prospective study. So there should not be any confusion. Clear? And sometimes we can have the mixed cohort also, means we are conducting a retrospective, but we still want to observe some more features after some time, so we can continue forward further as a prospective study. Now in the cross-sectional study, at that particular point, we are taking the observations, or like we can see the histopathology, maybe we had a cross section, and whatever is at that point we have to see. And what you can say like this, when we are making the still photography or we are having a video recording. So still photography is that who were present at that particular point is like a cross sectional. So if you compare the case control and the cohort study, the advantage of the case control is that it is the study of choice for a rare diseases. This is a question what has been asked, that which is the study of choice for a rare diseases. It is your case control study, and there is no loss of patients in the follow-up in the case control, so there is no attrition is seen in case control study, and obviously it is a cheap study, short duration study, and we can get a information about the multiple risk factors. But in the cohort study, if we talk about the advantages, that we can calculate the incidence, which is not calculated by the case control study. So advantage is that we can calculate the incidence. This is the only advantage. The rest all are the disadvantages, that it is a long study, expensive study. Then we are losing our patients in the follow-up. We can have the attrition seen. And the recall bias, it is seen in the case control study, but it is not there in the cohort study. Then the parameter, as I said, that odds ratio is calculated by the case control study, which is also known as the odds ratio, is also known as a cross product ratio. And they commonly ask the formula, that is this AB upon BC. And what in A or D is, A is means a true positivity and D is a true negativity by the false. Means if a risk factor is there, then definitely the disease should be there. And if the risk factor is not there, then disease should not be there. This is the true situation. By the false situation means disease is present but a risk factor is not there, or there is no risk factor and the disease is present. So it is a true situation. By the false situation is the cross product ratio, or AD upon BC. And this is giving us an idea about the strength of association between the disease and the risk factor. This is the interpretation of the odds ratio. And what the parameter we are calculating by the cohort study is incidence and relative risk. Relative risk is the risk ratio. Very commonly they ask about the formula. And the relative risk is incidence in exposed by incidence in non-exposed. The attributable risk is the risk difference, and this is incidence in exposed minus non-exposed by exposed. And the population attributable risk is incidence in total minus non-exposed by total. So remember these formulas very commonly they ask in the examination. And what is the interpretation of these parameters? The relative risk says that how much there is a possibility of or the risk of development of the disease in future. The attributable risk says that how much is the contribution of that risk factor in the development of the disease, and the population attributable risk says that by modifying the risk factor or by removing a single risk factor, how much prevention you are expecting in that particular disease, and this forms a basis of preventive policies. Then how you're interpreting the strength of association between the risk factor and the disease. So it can be calculated by both odds ratio and the relative risk. So the question is that which is calculating parameter is used to calculate the strength of association. Obviously the both parameter. Then the next question, which is the best, is the relative risk. And if the value of either the odds ratio or the relative risk is more than 1, then there is a positive association, 1 no association, less than 1 is the negative association. The cross-sectional study, it is also known as a prevalence study, which is used to calculate the prevalence, and here the unit of study is the individual, and this is based on the primary data. Means we are examining the individuals, collecting the information, while in the ecological study, it is based on the secondary data. We are getting an information from another source and we are analyzing the population characteristics. Okay. Then in the RCT is a randomized clinical trial. It is a type of random experimental studies. And here the important step is the randomization. Now randomization is done after we have selected the patients from the population. So from the general population, we are selecting our study population based on the selection criteria. And then this study population individuals by the randomization are divided into the two groups, the experimental and the control group. And this is process, this randomization, it is removing the known and unknown confounding error as well as the selection error. And then we had two groups, the experimental group and the control group. And the experimental group means either we are giving a new drug which we are testing, and the control group either we are not giving any drug or we are giving the placebo or we are giving the existing drug. And then we have collected the information, doing the analysis, and then finally we are doing their crossover. Now those earlier who were the control now become our experimental, and those who were the experimental now are becoming the control. And then finally we are doing a again reanalysis. This is again to overcome the unknown confounding errors. Okay. So the important step or the heart of the RCT is the randomization, and this is to avoid the selection error and to avoid the known and unknown confounding error. And by this, each and every person is having an equal and the known chance to come into the study. Then confounders, as we know that these are the factors which are unequally distributed in the study and a control group, and they had an independent effect on outcome. So another important question is asked that how we are removing the confounding error. So confounding error can be removed by matching as well as by randomization both, because the matching is removing only the known confounding error and the randomization is removing both known and unknown confounding error. So obviously the best is randomization. Then we are having the various errors while conducting the epidemiological studies. It could be the sample error because we are studying the sample population and it can be reduced by increasing the sample size. Well, we can have the systemic errors or these are the bias. It could be the subjective investigator or analyzer. The subjective means on the part of an individual who are in the study, and it could be the recall error or the Hawthorne bias or the attention bias because of their change in the behavior without the informing to the investigator or analyzer, or it could be because of anxiety is the apprehension bias, or it could be the investigator error because of the difference in the time given for the analysis or questioning, and this is the interviewer error, or could be the selection error. And we can have the analyzer error, the error during the analysis. Then the next part is that how we are correcting these errors. The very important is the blinding. And single blinding is correcting the subjective error, the double blinding is correcting the subjective and the investigator error, and the triple blinding is correcting the subjective, investigator and analyzer both. Now, if we say that which is the most commonly used blinding technique in epidemiological study, it is the double blinding. But if we say which is the best blinding, obviously it is the triple blinding, that where the subjective, investigator, and analyzer, all the three are not knowing about the patient status, that who is a control, who is in a study group, and they are giving their a neutral observation. The matching is removing the known confounding error. The randomization is removing the known and unknown confounding error and the selection error. Then what are the various phases of a clinical drug trial? We can have the uh, different phases. There is a different purpose and we are doing on the either healthy individuals or on the patients. So first is a preclinical trial or the animal trial done on the animals to look for the safety profile in animals. Then we can have a phase a zero or the microdose trial. This is done on the healthy individuals for the safety profile in very small doses. Then we can have the phase one trial. This is again done mainly on the healthy individuals, but if the drug is very toxic, it can be done on the terminally ill patients or the advanced stage of the disease individuals to look for the safety profile in the full therapeutic doses. Now, the phase 2 onwards trial 2, 3, and 4 we are doing on the patients, and the phase 2 we are doing for checking for drug efficacy and where the chance of the maximum drug failure happens. And the phase 3 it is done on the patients to compare the new drug with existing drug. And after the completion of the phase 3 trial, the drug is launched into the market. So after the phase 3 completion trial, the drug is coming into the market, and the phase 4 again done on the patients to look for the long-term side effects, and this is supposed to be the longest phase of a trial. Now, another important point as commonly asked, that you have to identify the given study. So we are identifying the study based on the two parameters. One is what is the direction of the study and what is the result. Or if we are having the result with us and the direction is a backward, then your study becomes the case control study. But if you are not having the results with you and the direction of the study is forward, it becomes your prospective cohort study. But if you had a result with us and the direction is forward, then it is your retrospective. So no confusion. If a result is with us and the forward is the retrospective, but if the result is not with us, only forward, it is your prospective cohort study. In the cross-sectional and ecological, it is at the same point, but in the cross-sectional, we are collecting the information directly from the individuals, that is the primary data we are collecting, while in the ecological, we are collecting the information from the other sources, that is the secondary data we are collecting. Then a few more questions are that what is the best study for rare diseases is the case control study. The study with the attrition means we are losing our individuals is the cohort study. The clinical phase which we do on the healthy individuals is the phase 0 and the phase 1 trial. On the patients, phase 2, 3, and 4. The longest phase is the phase 4. The post-marketing phase is the phase 4. The drug launch into the market at the end of the phase 3 trial. Now, if we talk about that, the importance of the epidemiological study, on the top of this pyramid is the meta-analysis where the multiple RCTs are analyzed. Then the systematic review means we are only compiling the results, not doing an analysis, is the systematic review. Then the RCT, then the retrospective cohort, prospective cohort, case control, cross-sectional, ecological, animal studies, and in vitro study. Now, please listen carefully. Now, here the question is that which is the best epidemiological study? Now, your answer will depend on what choices they had given. Now, suppose if this red group, if I say this is your group number 1, if the options are the meta-analysis, systematic review, RCT, and the prospective cohort, your answer is the meta-analysis because this is on the top. But suppose if your option group is this group number 2, that the blue color box, that RCT, retrospective cohort, prospective cohort, or the case control, then your answer will be the RCT. So the question is same and options, if they are different, your answer will change. So this can happen at so many places, and again I am repeating the same thing, that don't mug up the answers of the questions what you are solving for your practice. Read the options and you have to choose the best answer from the given choices. Remember this line. Then The best epidemiological study, if we say it's a meta-analysis, but the best analytical study. Now, here, please listen. The best analytical study will not be your meta-analysis, not the RCT, because analytical is the cohort, case control, cross-sectional, and ecological. So the best analytical study is the retrospective cohort, or we can say the cohort study. The famous cohort study is the Framingham Heart study, and that was a longest study, cohort study, and this was done for about 20 years to know the dietary risk factors of cardiovascular diseases. The nested case control study is not a case control, it is a type of the cohort study. The first step of epidemiological investigation is the confirmation of the disease or the verification of the diagnosis, not the confirmation of epidemic, remember. And how long to continue the study is till twice the incubation period of the disease from the appearance of the last case. And the best study for the natural disease history is your forward cohort or the prospective cohort study. And what is the Bergsonian bias? This is a type of selection error. What is the Hills criteria? It is the Surgeon General criteria of the causality. Multiple parameters are there, but the best parameter is the temporality, means the risk factor should always be present before the development of the disease. And by the prospective cohort study, we can assess the causality. So these are the important points in epidemiology. So here we'll take a short break of 15 minutes, and after that we'll again restart. Hello friends, welcome back. Now we'll be discussing about screening. As we all know that screening is secondary level prevention, and here we are trying to do the early detection of the disease so it can be treated in time and we can avoid complications so it can improve the prognosis of a patient. Now the question is asked that what is the lead time? Now don't remember like as a time interval between B to D is the lead time because examiner can change the starting points. So what you have to remember is the lead time is the time interval between the first possible diagnosis and the usual onset of the disease, and what is the screening time is the time interval between the first possible diagnosis and the final critical diagnosis, because if you are diagnosing after the critical point then there is no improvement in the prognosis. Now screening can be the prescriptive. It is for the benefit of individual. We always remember with a small mnemonic, and our mnemonic was that like a prescription is given to a person and that person has to take the medicine, not the family, not the mother, not the father. So prescriptive is for the benefit of the individual. The prospective is for the benefit of the community. Okay. So prospective screening, remember one point, it is actually a primary level prevention. So no confusion. If the simply they ask the screening is what level of prevention, your answer should be the secondary level prevention. But if they specifically ask that prospective type of the screening is what level of prevention, it is your primary level prevention because it is for the benefit of the community. The community has not developed the disease, but we are trying to protect from the individual that no problem should happen to the community. Very common example is the routine screening of the sex workers in those countries where this act is legalized, or we are doing the COVID testing of the international travelers earlier, or now currently also that we are trying to avoid the entry of the infection in our country, or they say that if we are doing a recruitment of any driver post, so we are checking for the color blindness of that person, so we should not be having the accidents because of the color blindness. So prospective screening is your primary level prevention. Remember these points. Or we can have the high risk screening. It is more cost effective if we are applying our screening methods to the high risk individuals only. It can be the multi-purpose screening when we are doing a more than a one test at a time. That is a multi-purpose screening, and like we are having the detection of various diseases in the pregnant mother, so we try to avoid the newborn baby, so we are checking for HIV, hepatitis B, hepatitis C, syphilis. So more than one disease if you are checking, it is the multi-purpose screening. And multiphasic screening is another type when we are applying a more than one test for the same disease. So if you're applying a more than one test, but for the screening of the multiple diseases, it will be a multi-purpose. Our purpose is multiple, detection of the multiple diseases. But if you're applying a more than one test for the same disease, like for the diabetes, we are having a blood test also, we are having a urine for sugar also. So this is a multi-phasic screening. Now, we all know that the result of a screening test could be either the positive or the negative. Like in the FMG exam, we all know our result is yes or no. So we had a one cutoff, and if our value is beyond the cutoff, it is a plus or the positive, and if our value is below the cutoff, it is minus or the negative. So we can have the plus side, the true positive also, the false positive also. On the negative side, we can have a true negative or the false negative also. So we are having the two important quality of a test, and these important qualities are the sensitivity and the specificity. Sensitivity is the true positivity, means out of the total disease individuals, how many it is able to detect truly by a test is the sensitivity. That's why straightforward question, the sensitivity is what? It is true positivity. The second question is that what is the formula? That is A upon A plus C. Now A is your true positive plus a C. Okay. Then the next is the specificity. The specificity is the true negativity, or it is D by B plus D. And what the D is? D is the true negative, B is the false positive. So it is D by B plus D, and B plus D are the total healthy individuals. So your formula for the specificity is the true negative by false positive plus true negative. Then the positive predictive value means out of the total false positive or false negative, or the true positive or the true negative cases. So how many are having the problem? So positive predictive value means out of the total test positive results. So test positive results are present in A plus B. In how many actually the disease is present, that is the A. So the positive predictive value is that A upon A plus B, or the true positive by true positive plus false positive. And the negative predictive value means out of the total negative test results, that is a C plus D, how many are actually healthy, that is D by C plus D, or the true negative by false negative plus true negative. Now these are the four formulas what we have to remember, and many confusion happens when we see these options in the examination. Everywhere we find a true positive, true negative, false negative, and it is very difficult to remember. So I had given you a very simple trick, and I'm very sure that you will not forget these formula forever. And the trick was that if you're talking about the sensitivity, in the numerator it should be the true positive. Clear? Then we had a numerator true positive in the two conditions. The one is in the positive predictive value, another is in the sensitivity. So if in the denominator all positive, that is true positive plus false positive, then it becomes your positive predictive value. So all positive, P, all positive, true positive by true positive plus false positive. Clear? But in the sensitivity, the numerator is the true positive, the denominator is opposite. So it is true positive by true positive plus false negative. So if the denominator is opposite of the true positive, false negative, it becomes your sensitivity. Clear? Now if it is the true or negative, then it can be formula for the specificity or the negative predictive value. We will very well remember the specificity is the true negativity. So true negative by false positive plus true negative means opposite of the true negative. If it is in the denominator, it becomes your specificity, and if it's all negative, then it becomes your negative predictive value. Clear? So all positive, true positive by true positive plus false positive, your positive predictive value. All negative is the negative predictive value, true negative by false negative plus true negative. But if the numerator is the true negative, then denominator, if it is opposite of the true negative plus false positive, it is your specificity. But if the numerator is the true positive and the denominator opposite, and that is true positive plus false negative, it becomes your sensitivity. So it's very simple, and you can remember these formulas, because sometimes they ask straightforward the formulas, or sometimes they can give you small numerical to calculate the sensitivity, specificity, predictive value, or they can give you a table, and they can ask you to fill the values, or they can give the values in the table, and they can ask you to calculate anything they can ask from this section. Then we are having the various relationships. Again, direct questions or the indirect questions has been asked on the relationship between the various parameters, and very important is the relationship of the prevalence. So disease prevalence is affecting the predictive value. Now remember one point, that sensitivity and specificity are the inbuilt criteria of a test. Like your height will never change. Now, if you're standing in front of a taller person, you will appear as a shorter. But if you stand in front of a shorter person, you will appear as a taller. But your height is constant. So, sensitivity and the specificity are the inbuilt criteria of a test. They are not affected by the prevalence. But yes, the prevalence can affect the predictive value. And the predictive value in turn is affected by the sensitivity, specificity. That is a different thing. But prevalence is affecting only the predictive value, both positive and negative, not the sensitivity, not the specificity. Clear? Now, the predictive value positive, it is directly proportional to the prevalence. Means if you are increasing the prevalence, the positive predictive value increases, and if you are increasing the prevalence, the negative predictive value decreases, because it is inversely related. So very commonly asked in a concept based question, that if a same test is applied in a two different communities having a difference in the prevalence, what parameter will be affected? Or if a prevalence of a disease is increased, the what will have effect on the predictive value? The positive will increase and the negative will reduce. Clear? Then another point is the sensitivity and the specificity, they are inversely related. Means if a test is highly sensitive, then obviously its specificity is low, and if the test is highly specific, its sensitivity is low. They are inversely related. Same in a study, if we are finding a false positive high, we'll have a less number of the false negative. Or if you are having a high number of the false negative, the false positive will be less because they are inversely related. Now, the another point they had asked is that if you are having a high false positive cases in our study, then this could be either we are using a test which is highly sensitive, or we are applying a test in a situation where the disease prevalence is low. So the high false positive results in our study can be because of the two conditions: either the disease prevalence is low, or we are using in a area with the test where the sensitivity is very high. But another modification of the test, what they ask is that if a same test is applied in a different communities, so the difference in the false positive cases would be because of what reason. So remember here, if you are using the same test in the different community, so the sensitivity of a test will be same, but still if you are having a difference in the false positive cases, it means only the prevalence is affecting. So if you are having the more false positive cases, then obviously the prevalence will be low in that area. And if you are having a low false positive cases, obviously the prevalence will be high in that area. So read the question very carefully before answering this type of the question. Then the diagnostic power of a test or the predictive value, as I said, it depends upon the both the test quality, that is sensitivity, and the specificity and the prevalence of the disease. But if I say that prevalence will be affecting what parameter? So prevalence will not affect the sensitivity and the specificity, but yes, it will affect the predictive value. Okay, so no confusion. So predictive value can be affected by the sensitivity and specificity, because if you are using a highly sensitive test, obviously its predictive value will be high, positive predictive value will be high. And if you are using a highly specific test, its negative predictive value will be high. But if we are using a combination of a test which is having a fixed sensitivity, specificity, then the prevalence will be the deciding factor for predictive value. If you are having a high prevalence of the disease in the community, then we will be getting a high positive predictive value. If we are having a low prevalence of the disease, we are getting a low positive predictive value but high negative predictive value. Clear? And the screening test, what we are choosing, the best quality is the sensitivity, because it is trying to detect the test first. So it will be detecting the true positive as well as it is also detecting the false positive cases. And then we have to apply usually the highly specific test to exclude these false positive cases. Then we will be able to confirm the disease. So screening is mainly done by the highly sensitive test, and the confirmation is done by a highly specific test. Then if you are applying a test in the series, means one test and after another test, and the sensitivity of the test decreases, specificity increases. As I said, that one after another we are using a highly specific test. Like in HIV, first we are using an ELISA, then we are confirming by the Western blot. So in the series, the sensitivity decreases, specificity increases, positive predictive value increases, and the negative decreases. While opposite happens if you're applying a test in parallel, means more than one test you are applying at the same time, then it will be giving us a more sensitivity and the specificity will be low, the positive predictive value will be reduced, and the negative predictive value will increase. Clear? Then we have to decide one cutoff. And if this cutoff is changed to a lower and a higher side, it will affect the test sensitivity and specificity. So if a cutoff is shifted to the higher side, then obviously the false positive cases will decrease. And if the false positive cases will decrease, the test specificity will increase. So if we are shifting the cutoff to a higher side, we are making the test highly specific. But if you are shifting the cutoff to the lower side, then our false negative cases will be decreasing. And if the false negative cases are decreasing, we are making our test highly sensitive. So shifting the cutoff to the higher side, the test is highly specific. Shifting the cutoff to the lower side, the test is highly sensitive. Remember this point. The commonly used screening test for the cancer cervix is the via and villi now we are using in the periphery because they are more cost effective. Because if you are using the pap smear, then obviously we require the expert cytologist for giving the report. But the cytologists are usually available from the district hospital onwards. So remember, if a patient is directly coming to the district hospital onwards, then we are not applying a via and villi, we are directly doing a pap smear. But if a patient is going to the PSC, primary health center, then we are using a via is a visual inspection after acetic acid, or the villi, that is the visual inspection after Lugol's iodine. Now, this is how the via interpretation is done. So, we are using a 5% glacial acetic acid and we take the cervix. So, the suspicious area having a higher nuclear protein or nuclear chromatin material, it is giving an aceto-white patch. So, if you are having an aceto-white patch which can be examined either by the naked eye with the Hind lens, so this area is suspicious and we are referring the person to a higher center for further diagnosis. And if you are using a Lugol's iodine, this Lugol's iodine, it is giving a purplish blue color with a starch. And we know that pre-malignant cells, we are rapidly proliferating, they are using their starch, so they are devoid of this starch. So if you are having a colorless area, that area is suspicious, and the area which is giving a purplish blue color, it is a healthy area. So if you are using a Lugol's iodine, getting a colorless area, or if you are using this acetic acid and getting a aceto white patch, both are suspicious and we are referring our patient to the higher center, or we can do either the colposcopy, or we can do the first pap smear, then we can do the colposcopic guided biopsy we can do, and finally for any cancer the biopsy report is the final answer. Clear? So these are the confirmatory tests. So diagnostic or the screening could be the via and villi in the periphery, pap smear in the higher centers, and then we can do the colposcopy guided biopsy, and that is the confirmation test. Clear? And we all know that this infection is caused by the human papilloma virus, and that's why now we are giving the vaccine. The two types of the vaccines are available, bivalent and tetravalent, that is Cervarix and the Gardasil. And this is given in the age group of 9 years to 26 years. That's an ideal guideline, but practically we are giving till up to the 45 years also. So better is that if you are giving before the start of the sexual activity, the almost 100% protection it can have. Then the breast cancer. We know that now the breast cancer is on the top. It is a world most number one cancer, or the leading cancer in both the sex, in the female also, and we cannot prevent or we cannot avoid. But yes, if we can do the early diagnosis, then simple mastectomy is the answer, and we can very well improve the prognosis. So we are advising the female community to undergo the self breast examination every month post menstrual. So again, this is my humble request to all of you who are listening me at this moment, or whenever you hear me, that you have to advise the two things to the female members of your family or whosoever you are coming in contact. The one is that they should regularly do their self breast examination, and they should receive the cervical cancer vaccination. Clear? Because these are the two important cancers seen in the female population, and cervical cancer we can say absolutely preventable, or we can have this early detection of the breast cancer. Then if a lady is having any doubt, she can go to a clinician and can get an examination, and we can have the further investigations. If a lady is less than 40 years, we'll prefer to do ultrasound first, or if required we can do a mammography or the MRI or the CT, but not the first because of radiation hazards. But if it is beyond 40, then obviously the fertility is not of a concern, then we can go with the mammography as a first investigation of choice. And then if doubt, you can go with the FNAC or the biopsy, and obviously the biopsy is the final answer. Then we can have the bimanual oral examination for the oral cancer that is very commonly seen in the Indian male population, or we can have the colorectal cancer diagnosed by the occult blood in the stool. And if we can detect the occult blood in the early stage, then obviously the good prognosis. And the detection of the TSH in the newborn baby between the day 3 to day 5 to diagnose the neonatal hypothyroidism. We can have a PSA test for the prostatic cancer, or we can have the routine BP monitoring for detection of hypertension, or the random blood sugar for diabetes mellitus. So these are the few important points what we have to remember about the screening. The next topic is a demography and a contraception. Now, demography, if we talk about that morbidity, it is not affecting the population, but it is affected by the mortality, marriage, migration, fertility, and social mobility. Social mobility means the movement of a family from the one socioeconomic status to other, and it is affecting the demography. That's the number of the human population. Now, we are having the two important groups of the indicators. The one is a vital indicators, and here very commonly they ask about their definitions. Now, the crude death rate is the number of the death per thousand mid-year population, and the crude birth rate is number of live births per thousand mid-year population. Now, currently, as per the revised data, now crude birth rate has been reported as 19.7. Obviously, this is per 1,000 mid-year population. Now that's why the growth rate will be coming to, because the growth rate is nothing that crude birth rate minus the death rate by 10. So our current birth rate is a 19.7, the death rate is a 6. So our growth rate will be, now it is the 1.37%. Now why we are dividing by the 10? Because the growth rate is always expressed as the percentage, and we know that a birth rate and the death rate we are expressing as per 1,000. So the current growth rate is around 1.37% as per the latest data. Then general fertility rate is the number of the live births per thousand mid-year population, the reproductive age group women. Then we are having the more specific is the general marital fertility rate is number of the live births per thousand married reproductive women mid-year population. Then we are having the total fertility rate. Total means the total number of the children in a family or the born to a woman alive. Remember, these are the alive children. We are not counting the stillbirth babies. But if a baby is dying few hours after, or baby is dying the few days after, the few years after, still we are considering as a live birth. Okay, so total live birth is the total number of the children born alive to a lady in her entire reproductive period. We are mainly concerned with the female children born, and that is the gross reproduction. You can remember as G for girl. So total number of the girl children born alive to a lady in her entire reproductive period. But main important point is that how many of these girl children are remaining alive till their own reproduction, means they will be the future mothers. So if they are dying before, then they will not be the future mother. So that is the net reproduction rate, means what is the net result of the reproduction, means they are taking like a business. So what is the net result of the business? When we do the business, we try to find out the net result, whether we had a profit or the loss. So here it is the net result of the reproduction, means those girl children who are born alive at birth, how many of them they will be remaining alive till their own reproduction, means they will be the future mothers. So here this is the total of the girl children remaining alive till their own reproduction. So the two important points has been asked is which is the most important demographic vital parameter, and that is the net reproduction rate, and another is that which is the only demographic indicator which includes the mortality. So we can have a demographic vital indicators. Demographic vital indicators which include a mortality. Now here don't confuse as a crude death rate, that is also including the mortality, but we are counting that the fertility indicator. So demographic vital, but it is the fertility indicator. So no confusion. So only demographic vital fertility indicator which includes the mortality is your net reproduction rate. Now one more point, that our goal of NRR is to achieve a 1. 1 means that when the mother is out of the reproduction, then her girl child will take part in reproduction. So this will be for stabilization of the population. Those countries like India, where we are having the increase in the population, now first we want to stabilize. So for the stabilization, our goal of NRR should be the 1. And how we can achieve this goal of NRR to 1 if we can have a TFR, or the total fertility rate, of 2.1, presuming some will die. So total fertility rate should be 2.1, and how we can achieve this total fertility rate as 2.1 if our more than 60% of the eligible couple will use any type of contraception. So these are the points we have to remember and commonly asked in the examination. Then, what are the various population indicators? The population indicators are, one is the sex ratio. Here they ask the definition. So it's a number of the female per thousand male, not the number of the male, remember. So it is a number of the female per thousand male. If you are calculating at the birth, it is the actual sex ratio. But if you are calculating within the first 6 years of the age, then it becomes the child sex ratio. Clear? So no confusion, sex ratio and the child sex ratio. So sometimes they can ask the small numerical also, so be ready for that. The next is the literacy rate, and we know that in the literacy rate they commonly ask the numerator and the denominator, specifically the denominator they ask, and the multiplying factor, because here we are not taking the whole population, we are not taking the live children, or we are not taking the the male children born or the female children born, but here we are taking the population of 7 years and above, because we cannot expect a 1 year or the 2 year old child to be literate, because the literacy means a person who is able to read, write and understand in their own local language. Doesn't mean they should know the Hindi, doesn't mean they should know the English or any foreign language. The local language they should be knowing. So the literacy rate is the number of the literate person per 100 population of the 7 years or the more, or the denominator is the population of 7 years or more. Clear? And here in the demography, we should be remembering the values as per our last census. Now, normally I say that commonly they don't ask the values, because these demographic parameters, with every study, it is changing. In every 3 months, 6 months, we are having the data published and the values changes. But yes, the values of the census, they remain constant for 10 years. So they will specifically say that what are the value as per the last census, means in the 2011 we had conducted our last census. So what can be the values as per the census? So the literacy rate as per the census in the 2011 was overall 74%, and for the male it was 82%, for the female it is 65%, because still in the rural areas the male education is being given the preference over the female education. But now the government is having a campaign, the Beti Bachao and Beti Padhao, means we have to save the girl child, improve the sex ratio, we have to give them the education, so they are not a burden to the family, to the society. They are independent, they can earn, they are having some vocational training courses, and those families where the female is quietly highly educated, then obviously the status of that family is very good. The children or the next generation are highly educated. Okay. Then the next is the dependency ratio. Now here very commonly they ask the numerator and the denominator. It means that a non-working population, how much is depending on the working population. Now in India, we consider the age less than 15 years or age more than 65 years is the non-working population, and the age between 15 to 65 is the working population. So dependency ratio is the non-working to the working, and again the small numerical can be asked on this. And the population density is the number of the person per square kilometer of the land area. Then we are having the demographic cycle phases. Now we are having the high stationary phase, phase 1. It means here the birth rate and the death rate both were high, but we were having the stationary population, because high birth rate, high death rate. Then starts the development of medical science, and various medical facilities were there. So we started to reduce the death rate. So death rate had started decreasing, but birth rate was high. So there was a gap increased, and we had a very high population. So towards the end of the phase 2, that is the early expansion phase, we had a very rapid rise in the population. Then with the further medical science, we had some contraceptive methods available, and we had started using the contraceptive methods, started controlling the fertility. So the birth rate further declines, death rate continues to decline. So this gap is reduced, but still the birth rate is higher than the death rate, and that is a phase 3 or the late expansion phase. The point to remember is that India is in this phase 3. So still we had a gap, the birth rate is more, and we are trying to control this. Then the phase 4 is low stationary. Population is stationary because of the low birth rate and the low death rate. So in the high or the phase 1, population is stationary. In the phase 4 or the low, population is stationary, but the reason is different. In the phase 1, it was a high birth, high death rate. Phase 4, the reason was the very low birth and very low death rate. And then we had a phase of 5, that is a reversal phase, where the natural death happens, but birth is in the control of the individual person. Nowadays, everybody wants to enjoy the life. They don't want to take the burden of bringing up their kids. So birth rate is almost the zero, and it is having the effect on we can say the environment, or ecosystem. So some countries are promoting to produce more children in that area, while in India, because we had a high birth rate, and we are giving the incentive to use the contraceptive methods. So these are the various phases of the demographic cycle, and commonly the questions are asked from this section. Then we are having the various data collection methods, and we know that the very important is the census, which is conducted every 10 years. We had a first disability census in 1881. Then 1921 is the year of the big divide, because at that point we had a low population from the previous census, and constantly population is increasing before and after that a cutoff point. Last census, that was a 15th census of India, we had in the year 2011, and the next census was due in 2021, but because of the corona pandemic we could not conduct it. Then we are having the control of this census activity by the census commissioner, which is working under the Ministry of Home Affairs. Then we are collecting the information every 5 months as a National Family Health Survey. And till today, we had conducted the 4 surveys. Every 5 years, we are conducting. Between the 92, 93, we had a first survey, 88 to 99, the second, 2005 to 6 is the third, and 14 to 15, we had the fourth survey. Then we are having the continuous registration of the birth, death, and the marriages as the civil registration system. And let's say that birth and the death should be registered within 21 days, and the marriage should be registered within 60 days. Then some birth, death, and marriage are not registered. So we have to arrange the vaccination, we have to arrange for the midday meal, for the schooling. And for that, we are conducting a very important survey that is very commonly asked in the examination, is a sample registration survey. The point is that it is a dual survey. Dual means two activities. One is there is a continuous reporting of the birth, death, and the marriage, and independent officer is conducting the sample survey every 6 months. That is important. And those who are not registered, they are being calculated, and based on that, the actual birth is decided. So the dual survey is the sample registration survey, and this is conducted every 6 months. Then we are having the population pyramid of each country, and it is a double histogram. The male and female parameters are there, and height is showing us the life expectancy. The shape is showing us the fertility pattern. In the India, the shape is the broader waist with a narrow tip, and the symmetry, it is telling us the sex ratio. Then how to control this population? Because the main concern is a rising population. That we are making development in each and every field, but it is all nullified by increasing population. So we are having the very important national program, National Family Welfare Program. And the guidelines of this National Family Welfare Program says that we have to mainly focus on the eligible couple. Now, eligible couple are those couple, means they are eligible for use of contraception. Means they should be between, or a female should be between the menarche to the menopause. Then only she can conceive. And if she can conceive, then only she can be protected by giving the contraceptives. But nowadays, still we see that age of menarche has been reduced to the 10 to even below 10, but on an average we are having between the 10 to 12 years. So as per my opinion, this should be changed, but still, for our examination purpose, we will remember this only, that the eligible couple are those couple where the age of the wife is between 15 to 49 years. Clear? Now, what are the target couples? The target couples are actually the type of the eligible couple who are mainly targeted for the use of contraception. And these are the couples who are having the two or the more live children, because we have to mainly target them that they should not have more children or they should not increase their family size. So the target couples are those couples having a two or more alive children. And as we had already discussed that a goal of NRR is a 1, and for that the couple protection rate should be more than 60%. Then we are having the guidelines and the logo of this National Family Welfare Program, and we are having the cafeteria approach. Cafeteria approach means that we are offering them a basket full of contraceptives, and they had to choose as per their requirement, as per their conditions. Then we are giving them the education, so they should be highly motivated and they should come forward to accept. So we are not forcing them to use, but they should come and ask us about the contraceptives, because we are giving them so much of education about the importance of the contraception. Then as we are delivering everything at home, then why not the contraceptives? So we are having the home delivery of contraception mainly by the ASHA workers, but village health guide can also deliver. We are having the gather approach of the counseling, and the spike approach is used in the cancer prognosis. Now, Nishchay kit is the pregnancy detection kit, and this is for early detection, and then they had to Nishchay, or they had to decide that what to do with this unwanted pregnancy, or this is a wanted pregnancy, whether they want to continue or abort. But no confusion with the Nikshay. Nikshay means share कहते हैं हिंदी में tuberculosis को. So Nikshay is a portal for the tuberculosis program. Now we are catching the woman at that point where she is highly motivated, and that point is when the lady is on the labor table, because she is in such an agony of the labor pains, and she says to the doctor, doctor, do something, I don't want the next pregnancy. So this is the right time to insert an IUCD, intrauterine contraceptive device, just after the delivery, postpartum. So this is PPIUCD. We are inserting the device IUCD just after the delivery, to be inserted preferably just after the placenta expulsion, but we can put up to the next 48 hours, not beyond that. And the device what we are using is the copper T380A. Ideally, though, this is lasting for 10 years, but we are not keeping for 10 years. Whenever the patient demands or patient wants a second child, then this IUCD can be removed. Okay, but the disadvantage is, because the bigger size of the uterus, we are putting a small device, so there could be the chances of expulsion. But still, what we say na, bhagte bhoot ki langoti bhali. So whatever is the possibility of retention, we are taking the advantage of that. Then we are having another national activity is the Chaya. Chaya is the shadow or cover. So those women who either not accepted the IUCD insertion, or they didn't tell the doctor had forgotten to insert the IUCD just after the delivery, and they want contraception, because at this moment we cannot give them a combined pills, so we are giving them the Chaya tablet, that is a non-hormonal oral contraceptive, or meloxifene tablets. So this is given in a lady just after the delivery, because this is safe in lactation. And another point is that it is having the quick return of fertility, and this is an advantage over the other contraceptives like a DMP injection, which is taking almost a year for the fertility to return back. And this is a selective estrogen receptor modulator. For the first 3 months, it is given twice a week. Then it is given once a week. So this is also known as hafte ki ek goli. And always remember that whenever we are giving a progesterone preparation for a long time, or we are giving a Chaya, it is causing the amenorrhea. Initially, menstrual irregularity, bleeding, spotting, then leading to amenorrhea. So we have to make it very clear to the patient that you might be having the amenorrhea. Otherwise, that lady will eat your head. Bar aake kahegi, doctor, I am not having the periods. I had checked my urine for pregnancy test 2 times, 3 times, and I think I had entered in the menopause, now I'll have this problem, that problem, and you have to tell them that this is because of the drug which is causing an endometrial atrophy. Because of that you are not having the periods. Once you stop using those medications, the endometrial proliferation will happen and you will have your periods back. Okay, then we are giving the injectable progesterone preparations as Antara, and the commonly used is the DMP injection, depot medroxyprogesterone acetate, which is containing 150 milligram of this preparation every ml, and it is given deep intramuscular. Every 3 months we have to repeat. And only drawback of this is that it is again having the amenorrhea, and there is a delay in return of fertility up to the 1 year. So we tell them that patient should stop using the injection before 1 year of their planned pregnancy. Now we are having the gap between the knowledge, attitude, and the practice, that is the gap, and this is seen in contraceptives and sexually transmitted diseases. And we are having the unwanted need of contraception. The contraception is demanded, but it is not fulfilled, and that is unmet need of contraception. We are having the eligibility criteria for a couple undergoing the permanent sterilization or the permanent contraceptive surgeries, that they must be one child of more than 1 year age, because we are seeing the high infant mortality rate. So we want that a child should cross that dangerous first 1 year. Otherwise, if you are doing a ligation just after the delivery and suppose anything happens to that baby, and they will come to you, the doctor now operation khol dijiye, now you do a reversal operation. So it is not a just a joke that whenever the patient is coming, you do the surgery. Whenever the patient say, you open the surgery, because it's a bigger major surgery, complications are there. So there must be the one child more than a 1 year age alive. And female should be in the age of 22 to 49 years. The male should be less than 60 years. And the verbal consent of the husband is adequate now. Now we are having the mission Parivar Vikas. The mission Parivar Vikas means Parivar ka development. So we are promoting for the use of family planning methods in those areas where we are having the high total fertility rate. Now, what are the various contraceptives we are advising? Now, we can have the temporary methods or the permanent methods. Now, temporary means reversible. When the person stops using, the person can become pregnant. Or permanent means they are theoretically we say that for examination purpose or for explaining to the patient that they are the non-reversible. But yes, with the advancement of the medical field, we can do the reversal surgeries of the tubectomy or vasectomy also. But we are not saying to the patient, otherwise it will be a game for them. Now, temporary methods could be the natural. It means we have to detect the time of ovulation and we have to take a precaution at that time, either by the calendar method, basal body temperature, or the billing method, or the locational amenorrhea. Or we can have the barrier methods, means putting a barrier between the ova and the sperm, either by the condoms, it could be male or the female condoms, or we can be by the cervical cap or the vaginal tablets. The main function is that they are putting the barrier. But other question they ask is that what is the non-contraceptive advantages, that it is protecting against the sexually transmitted diseases, and that's why it is the best or the preferred method of contraceptive for the young adolescents, because they might be having the multiple partners. But one drawback is that they are having the high failure rate. So if we are advising them to use with the spermicidal gel, then their efficacy can be increased. So the best for the young adolescents is that condoms with the spermicidal gel. This is the best combination. Clear? And the question is that what is the compound in the spermicidal gel? It is the non-oxynol 9, which is killing the sperms. Clear? Then if you are advising the cervical cap, because special training is required to insert and to remove. So this is preferred in a woman beyond 40 years, but if she is highly educated. Because beyond 40 years, we usually don't advise the IUCDs, because IUCD is causing menstrual irregularity, and after 40, around perimenopausal, the lady itself is having a menstrual irregularity. So it is very difficult to differentiate whether this irregularity is because of IUCD or it is because of the hormonal changes. So we usually not advise the first preferred method of contraception after 40 or we are not giving the combined oral pills also after 40 because of risk of side effects. So if a lady is beyond 40, highly educated, then we advise for the cervical cap, and if it is not that educated, we'll advise for the barrier methods with the spermicidal gel. These are the few images of barrier methods. This is the male condom having the single ring, the female condom having the double ring, and this is how this female condom is in place. And this is the cervical cap, and this is filled with the spermicidal gel. And these are the spermicidal gels available in the market. And this is the vaginal tablet. Actually, vaginal tablet, it is to be capped or to be dipped in a water just before insertion, because it will swell up, and then it has to be kept in the posterior fornix and to be removed after 6 hours of intercourse with this loop, by hooking this loop, and it has to be taken out. Then we are having another group is IUCD, very commonly asked in the examination. Then we are having the different generations, but currently we are using the second generation and the third generation devices. The second generation is your copper containing device, and the mechanism is to prevent the fertilization, and this is depending upon the amount of copper, and this numbering is the surface area of the copper in the square millimeter. The copper T380A or copper T220B. These are the two very commonly used IUCDs available free of the cost from the government center. And multi-load 375 or the 250, the lady has to purchase from outside. Then we are having the hormonal devices. The hormonal devices, we are having the Mirena or LNG20. And it is the progesterone, and it is inhibiting the ovulation, changing the cervical mucus, or changing the endometrium also. And we can have the fourth generation is the frameless devices, where we had only the copper wire, no a frame is there, and the function is, or the mechanism action is prevention of the fertilization, same as the second generation devices. And this is the FlexiGuard, which is available in the market. So these are the various images, and this is the Lippes loop and the Grafenberg ring, not used nowadays, the first generation devices. This is the image, very important, we have to remember, is the copper T380A. The copper is present on the horizontal as well as in the vertical arm. And always remember for IUCD to say that there must be the thread hanging, because this thread is hanging in the vagina, serves the two functions. Number one, when the lady is coming for the follow-up, and we can say that device is in place, and this thread, if it is not seen, so either the device is misplaced or the thread has been broken and expelled out, and we have to do the investigation. And second is that when the lady wants its removal, we can just pull this device through this thread and the device is removed. And this is how the IUCD intrauterine device, and this is not having any copper wire, but it is having the capsule seen on the vertical arm, and this is a hormone containing capsule, so this is Mirena. Okay, most probably it is Mirena. And this is how the multi-load it is looking like. It is not a T-like structure, but it is having a shape to adjust as per the uterine cavity, so it is causing less irritation and the pain, but this is not available free of the cost, the person has to purchase. Now one more point they ask from this Mirena section, that how much is the daily release of the hormone, as the name is LNG20. So it is releasing the levonorgestrel 20 microgram per a day is released, LNG20. Okay, and this is what is a FlexiGuard. This is a copper wire with the thread, and this is hooked into the myometrium, and the thread is hanging down into the vagina. So these are the various IUCDs, and they commonly ask about the lifespan. We have to remember for the two devices, that copper T380A lasting for 10 years, and the Mirena, it is lasting for 7 to 10 years. There is some controversy. Some guidebooks or some says that it is for 5 years, but your PARC textbook clearly mentions that it is for 7 to 10 years. For the therapeutic purpose, yes, we are changing after 5 years, because the concentration of the hormone is reduced, so it is not able to control the bleeding problems. So for the therapeutic purpose, we are removing after 5 years, but if they are talking about the contraceptive purpose, we can keep for 7 to 10 years. Then another point is that what is the Time of insertion, the best is post menstrual because we have to rule out the pregnancy of a previous cycle, but preferred is postpartum, and it is the best method for the birth spacing. And very important point they ask is that what are the absolute contraindications? Absolute is the past history of an ectopic pregnancy, presence of inflammation, or the suspected pregnancy, or the history of undiagnosed bleeding per vagina. But the relative contraindications are the nulli gravida, the past history of the pelvic inflammatory disease, anemia, fibroids, any malformations, or the high possibility of the STDs because of the multiple partners. Then, what are the various side effects? The most common is the bleeding, but we are not removing the device when the patient comes with the bleeding. We have to convince or reassure with iron folic acid tablet. We should watch for 2 to 3 months, but if still the bleeding is continued, then we will think for removal. But immediate management is a reassurance with iron folic acid tablets. But if the patient is coming with the pain suggestive of the infection, then we have to remove the device immediately and we have to give the antibiotic. The next question is that if a lady is coming with the pregnancy, means IUCD has failed, and then what to do or how to proceed. So we have to do the removal of a device by pulling the thread. Remember, in pregnancy, we are never putting the hysteroscope. Non-pregnant may, if it is a misplaced property, then and inside the uterus, then the preferred is that we can do the hysteroscopic removal. But if it is a pregnant uterus, then we try to remove with the pulling the thread. And if the patient wants to continue the pregnancy, then we have to look for the viability of the sac. If the sac is viable, alive, then we can continue. And if the sac is dead, then definitely we have to do the termination. And the patient is not willing at all. She says that I had used the device because I didn't want the pregnancy. Then obviously we have to do the medical termination of the pregnancy. Now here, one important point, the question comes in the mind that if we are not removing the device, and suppose if it is left inside, what it will do. So it is not causing any congenital malformations in the baby, but as it is in the uterine cavity, most probably or most commonly it is getting incorporated into the placenta, and it is not affecting the sac, but many times it can cause the infection inside the uterine cavity, or it can lead to the premature rupture of the membrane or the premature baby. So that's why we try to remove the device. But if it is not able to be removed, the thread is not visible, and then we leave as such, and we just see the placenta after the delivery, whether the device is expelled with the placenta or not. Okay, so these are the more practical points you have to remember. Then we can have the expulsion. Same as said that in the follow-up, if a thread is not visible, so we have to look for the thread. If we don't find the device anywhere, and we say the device has been expelled, but if thread is not visible and we find the device inside, then we have to do the removal. And how we can check the device is inside, either by the X-ray or the ultrasound. So if the X-ray or the ultrasound says that the device is inside the uterine cavity, then we have to remove with the hysteroscope. But if they say that device has been perforating the uterine cavity, it has gone outside, then in that case we have to remove by a laparoscopy. Clear? And if the device has been displaced within the uterine cavity, again it can be removed by hysteroscope. So we have to locate the device, or we can have the ectopic pregnancies also. So these are a few important points about the IUCD we have to remember. Then we are having the various hormonal methods also, and the non-hormonal methods also. And these are the few images of non-hormonal, like we had a Chaya tablets, as we had discussed, is the non-hormonal methods. And these are the few images of emergency contraceptives like an I pill or unwanted 72. This is your abortion kit. 5 tablets are there. 1 tablet is of mifepristone, 2 are the misoprostol, and this is the Nixche kit, or the urine pregnancy detection kits are there. Now we are having the various groups of hormonal methods, and in the hormonal methods we can have the combined hormonal preparations, that is Mala N, available free of the cost by the government center, or we can have the Mala D counterpart, which a lady can purchase. Okay, so remember that combined tablets usually the 21 are the active tablets. So we are having the two type of the packs. In one pack we are having only the 21 tablets, in another we are having the 7 more additional iron tablets. So this is just to maintain the regularity, that lady has to take a one tablet, or some iron preparation has been supplemented to overcome anemia, what we commonly see in our Indian women. So here the tablet is started from the day 3 to day 5. Daily patient has to take the tablet, and when these 21 tablets are over, then actually the pill free days starts, because pill free days means we say that our hormonal tablets are not being taken, and during that pill free days we are having the withdrawal bleeding, and during that phase the iron tablets are continued, and from the next day of completion of this pack, the lady can start the next pack if she is using the 28 tablet pack. Now mechanism of action is it is inhibiting the ovulation. The another point is that what is the composition of these tablets. Now if we talk about the composition of these tablets, now each hormonal tablet, it is containing the ethinyl estradiol of 30 microgram. Remember the units, 30 microgram or 0.03 of milligram, and the levonorgestrel is 150 microgram or 0.15 of milligram, and the 7 iron tablets, each iron tablet is containing the 60 milligram of the ferrous fumarate, and having the 19.5 milligram of elemental iron. And important point is that some cancers are protected with the use of OCPs, while some cancers are increased. So the cancers which are protected or the reduced with the help of OCPs is the ovarian and endometrial. Now the question can come in your mind that how this is reducing the possibility of these two cancers, because we know that the mechanism of action is ovulation inhibition. So we know that there is no breakage in the or the breach in the continuity of the ovarian epithelial lining, because no ovulation is happening, and that is actually the trigger for the ovarian cancer. When we don't have a trigger every month, then we are having the lesser chances of the ovarian cancer. Now how it is reducing the endometrial cancer, while we say that estrogen is increasing the possibility of the endometrial cancer, but along with the estrogen we are giving the progesterone from the early days, or from the day 3 or the first tablet. So estrogen with the progesterone, it is not causing the proper growth of the endometrial lining, and we are stopping, means every time or every month we are having the withdrawal. So whatever the endometrial lining is prepared, it is obviously the thin lining, but it is being shed off. So we are not having the possibility of making this endometrial lining thick, and we are not having the possibility of the carcinoma. So that's why it is reducing these two cancers. Then how this OCPs are increasing the possibility of the a few cancers, like a breast cancer because estrogen dependent, and cervical cancer, because they say that actually cervical cancer is because of the human papilloma virus, and they say that this hormone is increasing the risk of HPV infection, or making the cervical tissue more susceptible to the HPV virus in the presence of these hormones. So more possibility of cervical cancer. And another school of thought is that as the lady is having the oral contraceptive pills, so she is coming for more follow up, and in that we can early detect the condition. And the hepatocellular, because these hormones are metabolized into the liver, there is a high possibility of hepatocellular cancers. Then we can have again certain contraindications. The absolute are the family history of the breast cancer, history of deep vein thrombosis, cardiovascular diseases, liver diseases, congenital hyperlipidemia or undiagnosed bleeding per vaginum. And some relative contraindications are the lactating woman, because they say that especially in the first 6 months of the lactation, the combined preparations are not given, because estrogen is supposed to be decreasing the breast milk volume. So in the first 6 months, if we say that which hormonal contraceptive is preferred, then it is the progesterone only preparations are given. POP pills and the progesterone only pills are given, not the combined pills. Clear? In a lady more than 40 years, non-smokers, because after 40 there is a possibility of the cardiovascular problems. But if a lady is a smoker, then after 35 years to be avoided: history of the migraine or the diabetes mellitus, hypertensive, a lady, or in epileptic patients. So, what could be the side effects? Actually, those are the contraindications, could be the side effects. That's why we are not giving in that situation. If they are already present, like a deep vein thrombosis, the cancers, could be the breast, cervical, hepatocellular, are increased. The cardiovascular diseases can happen. Possibility of the migraine, weight gain. This is again a very important point. Practically, we have to tell to the woman very politely that you might gain a weight of around ranging from the 2 to 5 kgs, because that is very delicate aspect for a lady who doesn't want to put on the weight. And many times you see that they tell us very clearly that, doctors, since I started using these tablets, I had put on the weight. एंड समटाइम्स हम पेशेंट के सामने इग्नोर कर देते हैं, नहीं, टैबलेट से कुछ नहीं है. बट द फैक्ट इज, यस, इट इज having a tendency of the fluid retention, so they can put on the weight. And because of the change in the vaginal flora, and there is a possibility of the candidal infection or the monilial vaginitis, then cholestatic jaundice can happen. Then another practical problem is, sometimes they ask that if a lady is on OCPs and she is missing the tablet, what to do? And she is missing the one tablet, then we say that she has to take a tablet as soon as possible and continue with the other tablets as per the schedule. But if she is missing the two or the more tablets, we say that okay, you have to discard the missed tablets but continue with the rest of the tablet. But there is a possibility of the failure, so you have to use an additional contraceptive methods, and you have to wait for your period. And if you don't have the period, then you have to get your urine pregnancy test done. So these are the points about the oral form of hormonal preparations. Then we can have our injections also, and very commonly we are using the DMPA injection, and that is given every 3 months, and amount is 150 milligram per ml of depot medroxyprogesterone acetate. We can have a nitin also, which is given every 2 months. It is having the norethistron ananthate of 200 milligram per ml. You can remember as a 2 months 200, 3 is 150. 1.5 double is the 3. And we are having the modification of the DMPA, but that is given as a subcutaneous route, smaller amount of the DMPA 1004. The mechanism is same like progesterone preparations, inhibiting the ovulation, changing the cervical mucus, and changing the endometrium. And we are having the delay in the return of fertility. Then we are having the other formulations, like we are having the implants also, the Norplant 6 2, we are having the Norplant 1 now, the single rod implants also. And single rod is now preferred, because earlier the acceptance of the Norplant 6 was not very good, because we have to just give a one nick to put these 6 rod implants, and after 5 years you have to give another nick to remove these empty rods. And no patient wants a surgery sort of thing. Even a one stitch is the surgery for them, to put a contraceptive device and another surgery to remove the contraceptive device. Why to undergo the surgery for contraceptive purpose? So they don't accept it. But now this is a single rod, which is we are putting for 3 years, and there is no need for the removal also. So this is your implants. Now we can have the vaginal rings. Vaginal ring is again combination of the estrogen and progesterone. We are putting for 3 weeks, removing, having the withdrawal. Or we can have the skin patch also, again putting for 3 weeks. One patch is lasting for 1 week. So always remember, the contraceptive pack is for whole 1 month. So if it is the estrogen and progesterone combination, it is for whole 1 month, means the 3 weeks we have to use. We'll remove or stop, then we'll have a withdrawal bleeding. But progesterone preparations can be continued for a longer. So jitne bhi long acting preparations hai, means for more than 1 month if we are using them, then they are definitely the progesterone only preparations. Clear? Not the estrogen and progesterone combination. That we cannot use beyond 1 month. Remember this point. Then we are having the permanent method of sterilization. For the female partner, it is the tubectomy. For the male partner, it is the vasectomy. Now, the important point to remember is that we are promoting for the vasectomy because it is more cost effective. Cheaper cost, we are having the better results, the lesser stays there, the less family affection or the suppose if a female is affected in a family and we advise the bed rest, then the whole family suffers. But if a female is working, husband is taking rest, that female can manage the family. So in the vasectomy, we are advising only the 7-day rest, while in the tubectomy, we are advising the 14-day rest. So more cost effective is the vasectomy, but practically it is not the situation. And if you see practically, the more of the tubectomies are being done over the vasectomy, because the false myth they had in their mind that if a male partner undergoes the vasectomy, there could be the affection of the sexual functions, but actually this is not the possibility or not the fact is. So we have to give them the education, we have to motivate them that more and more people should come forward to accept the vasectomy surgery. So important point is that after the vasectomy surgery, and here the question is framed, that we have to advise the 3 additional months of barrier method of contraception, because the failure possibilities can be there, while that is not required following the tubectomy surgery. And the most common cause of the failure is a wrong identification of the structure, and that's why they say that whatever the piece we are removing, it has to be submitted for histopathological examination. The tubectomy we can perform either the surgical procedure as cutting the tube, or the non-surgical by Escher implant, and the surgical can be by the mini laparotomy or laparoscopy. So the question is that just after the delivery, what type of tubectomy procedure you will prefer, because just after the delivery the uterus is a bigger size up to the 24 weeks of the or 20 weeks of a gravid uterus, reaching up to the umbilicus, and this is the side where we put the laparoscope, so we can perforate. So just after the delivery, the method of tubectomy is the mini laparotomy, not the laparoscopy. Remember, another point is that if a person is having any cardiac problem or the respiratory problems, as for the laparoscopy, we have to inflate the abdominal cavity. We have to put a gas or the air that is irritating the diaphragm. So again, it is not preferred. Means the laparoscopy it is not preferred. If a patient is of a cardiac or the respiratory disease, then we can go with the mini laparotomy. Now the next point is that how we are ligating the tubes. In the tubectomy by laparoscopy, we are ligating by the either Fallop ring that is commonly used, or the Hulka's clip. Hulka's clips are costly, but a plus point is that in future, if we have to do the tuboplasty surgery or the reversal surgery, the maximum success rate is with the Hulka clip because of the minimal tubal damage. Now, in the mini laparotomy, we are ligating the tube by modified Pomeroy's method, where we are having the double ligature. Clear? Then the non-surgical method, that we are putting a titanium implant through the hysteroscope on both the cornal ends of the fallopian tube, and it is causing the inflammation, fibrosis, and this takes a 3 months time. So we are not cutting the tube but blocking the tube, and it is equal to the permanent sterilization. And these are the few images that we should remember. This is cutting the vast difference is the vasectomy procedure. This is ligating a tube by making a loop, cutting, putting a one ligature, or we can have the another ligature also, the double ligature, that is the modified Pomeroy's procedure, or we can do by the laparoscopy. We can put the scope through the umbilicus, we can hook the tube, and we can put this is the Fallop ring, or we can apply this is the Fallop ring in place, and this is what is the Escher implant, and this is through the hysteroscope. It is kept bilaterally on the tubal conus. Then what are the emergency contraceptives? Emergency contraceptives is the post-exposure prophylaxis. It is again a primary specific prevention, because exposure has happened but not the pregnancy. So a lady wants to avoid the pregnancy even after the risk factor. So if we say that highly efficacious is if you're putting an IUCD within 5 days, but it is not practically preferred, because the lady has to go to the center for IUCD insertion, and there is always a breach in the confidential area. So most commonly used or the most preferred is the LNG tablet, what we are available in the market as unwanted 72 or I pill. 1.5 milligram tablet, single tablet to be given within 72 hours. So very commonly they ask a question like this, that lady reported after 40 hours of an exposure, after 90 hours of an exposure. So be very careful. Except the IUCD, the all other methods we are used still 72 hours. And if we have to use after 72 hours or the 3 days, then we have to go with the IUCD. But within the 3 days or 72 hours, we will be preferring the LNG tablets. Or we can go with the OCPs if it is available. Then this is called as a Usupirazine. The 4 tablets start within 72 hours. 4 tablet again after 12 hours of the first dose, but causing a high nausea, vomiting. Or we can have the ulipristal or mifepristone also. And how we can assess the efficacy of all these methods? The efficacy can be assessed the best is by the life table analysis, where the monthly analysis is there, but in the exam they ask you the Pearl index. And the point why they ask it is it's a specific formula and definition. Now here we are calculating the accidental pregnancies per 100 woman year of an exposure. That is important point. And per 100 woman year is equal to the 1200 months. So any question they can ask that the Pearl index is what is the number of the accidental pregnancies per 100 woman year of an exposure per 1200 month of an exposure, or in a formula form if we write number of the accidental pregnancies by the total months of an exposure into 1200. And in this way we have to solve the small numerical also. And remember one point, that in the community medicine very smartly any simple formula can be very well converted into a small numerical. So we should be knowing the formulas, could be the numerator, could be the denominator, what is a multiplying factor, okay? Because all the options are given, the examiner knows that on what wrong track you can move, and all the options will be sitting there. So be very careful about the formulas, and I hope, I always say in the classes that write the formulas on the one page, on the back page of your notebook. So all the formulas should be at one place, and quickly you have to revise before going to the exam. And the Pearl index are the few important methods we have to remember. For Mirena it is 0.2, for DMPA it is 0.3, and chai tablet it is 1.8 to 2.8. These are asked in the previous exams. The diaphragm it is a 12 and having a high failure rate. So these are the few important points about your demography and contraception. Now we can discuss another topic as biostatistics. Again, it's a very vast topic, but we have to focus on the important points that are very commonly asked in the examination. Clear? Now here the data we can have based on the measurements. It could be the quantitative or the qualitative data. So very commonly they ask that we have to identify the data, then how we are representing the data, how we can do the calculation for these data, so and what are the errors we can have. Okay, so based on the measurement we can have a quantitative where the measurement is possible, and the qualitative where it is not possible. Or based on the number we can have the continuous, means the in between values are there, the decimal values are there, that multiple values are in between the two ends. And the discrete means no in between values, or very few values are there. So this is a discrete data or continuous data. But very important point is that how we are expressing or representing those data. The quantitative data can be expressed by the histogram, frequency polygon, curve, line chart, or the scatter diagram. Or we can have the qualitative data presentation as a bar chart, pie, spot map analysis, or pictogram. Now these are the images, very very important image, commonly asked in the examination. Okay, now please see carefully these two images I had kept at one place. Now in the image number of 1, you may find the gap between these bar. Okay, so it is not continuous. So when it is not continuous, so by looking at the height of the bar, you can see that which value is more. And this is number 1 image is your bar chart. If it is a continuous value back to back, but we don't had a gap in between the bars, then this is your histogram. Okay, so if there is no gap, it is your histogram, but if there is a gap, it is your bar chart. Now don't confuse with the another type of a bar chart, that is a multiple bar chart. Okay, just give me a minute, I'll show you that image also, that how this multiple bar chart looks like. So these are the two more types of just a minute. These are the two more type of bar charts are there. Now, this is what is the simple bar chart that is asked in the examination, and this is the multiple bar chart. Now, you will say that here there is no gap in between these two bars, and you may label this as a histogram. But remember here what they are doing, that they are taking the multiple qualities at the same time. Clear? So obviously after this there is a definite gap is seen. So multiple qualities they are taking at a time. Like in this, they had shown the population of the different countries, and they had taken as a blue bar as a population in the 1980, the red bar is in the 1990, and the green bar as a population in the 2000. So multiple features they are taking at a one place. But definitely after that there is a gap, because they are talking about the different areas. So no confusion with the histogram. Now histogram mein there is no gap at all. Clear? While this is the multiple bar chart. So this is a variant of a bar chart. And one more point you can have, the practical point is that if we had a multiple bar chart, that definitely the same color protocol will be followed, because they are representing the one feature by the one color. Remember this tip, that you can differentiate. Clear? And this is the component bar chart. Sorry. This is the component bar chart. Component means on a one bar, they are having the different components. And as per that, it is showing as the percentage of that value. So here they are saying that in the one city, they are showing a blood group. Means how much of a population is having the blood group of O, how much of the population is having the blood group of A, how much is population having a blood group of the B, and how much is the AB, like that. So the different qualities in a one bar they can show. This is a component bar chart. So these are the varieties of the bar chart, but no confusion with the histogram. Clear? Now, if we are preparing the basic histogram and joining the center point on the top of these histogram, and like join the dots game we are playing, and what we are having is the frequency polygon. So base is the histogram, and the top center point is being joined is the frequency polygon. And if the frequency is too much, so their bar width is very small, and when we join these points it gives a curve like structure. This is the frequency curve. So all these three, the histogram, the frequency polygon, and the frequency curve, it is used for the continuous quantitative data. This is the one point they ask, and out of these three the best is the histogram. Clear? Now the next is a line chart. Again, this is asked, and they say that which is the graph we are using to show the relationship between the two parameters or trends of the events over the time. Means over the time, that what is the value, or the what is the trend, means the cases are increasing, the cases are decreasing, the percentage of the children vaccinated are increasing or the decreasing, whatever the value they say, that it can go in any direction. There is not a necessity that it is always increase, always reduce. So it is showing simply the relationship between the two parameters or trends of events over the time. Now, if we are having a certain relationship between the two parameters, then we are representing by the scatter diagram, and in this, where we are finding the maximum values concentrated, we make an imaginary line. So if we are getting an imaginary line in an increasing trend, it means on increasing the one parameter we are having the increase in the other parameter, or if we are having the line in the decreasing trend. It means if you are increasing the one parameter, the another will reduce. So scatter diagram is used to show the degree of association between the two parameters, and we can calculate the correlation coefficient also by the scattered diagram. So the point is that scatter diagram is used to know the degree of association, and correlation coefficient is calculated, and as I already discussed, the range is -1 to +1. And here quickly revise, the range of PQLI is 0 to 100, and range of HDI is 0 to 1. And one more question sometimes they ask, if they're giving any value beyond the range. Means whatever the number of question paper you had, you cannot have a marks more than that. So if you are having the value of like if I say the correlation coefficient, suppose they say in a study it is coming as a +2. So what is your interpretation? You don't say it's a highly or a strong correlation, but this is a wrong calculation because value is beyond the range. But if they say that a correlation coefficient is +99, yes, I'll say it's a strong association between the two parameters, and that is the positive. If you're increasing the one, it will be increasing the other parameter also. So interpretation is, if the value is between -1 to 0, it is a negative association. But if it is a 0, it means there is a no association. And if it is towards the plus side, it is the positive association. Clear? Then we are having the qualitative data presentation. As we had already discussed the various type of the bar charts, and we can have the pie charts also. Here the values are expressed as per the 360-degree or 100%, but total sum of all the values should be the 100%. Then only we can have a pie chart. If a total value is not 100%, then we cannot make a pie chart. Now spot map analysis means on the spot a map of that area, we are just showing some events. As we had discussed, John Snow has used this method to locate the cholera cases, and the pictogram by pictures we are depicting the values. So qualitative methods, simply by observation we can say that which value is more, which is less, but in the quantitative data presentation methods we have to do the calculations. Now if you want to do the calculation, then we can do the measurement of the central tendency or the dispersion. The central tendency can be measured by mean, median or mode. Mean is simply the average of all the values, and the formula is x bar or the mu is equal to the sum of all the values by n. Or we can have the median, means if you are arranging in the ascending or the descending order, either the middle value as in the odd number or the average of the middle two, if it is an even number, will be your median, or the most commonly occurring value is your mode. Here the few more questions has been asked. The mode can be more than one, okay, and mean and median are always the single value. Now if we have to represent the mode in a unimodal way, it is not preferred over the multimodal. So multimodal is the best way, or the actual mode value we have to express. Otherwise we can take an average of these values also to calculate a single mode. Then if we have to measure this central tendency, and if it is the nominal data, when we are arranging the values as per the name, we will prefer the mode as a central tendency. If we are using an ordinal data, then we are using the median as a central tendency, and if we are using a metric data, then we can calculate the mean, and we are preferring the mean as a central tendency. Then what are the outliers? Outliers are the extreme values in the given situation, and it is mostly affecting the mean value, and the least affected is the mode, but in that situation the preferred is the median. So remember these points. Then we are having the various measurement of the dispersion by a range, standard deviation, or we can have the standard error, we can have the relative deviate, we can have the regression. So a range is nothing but the value between the two ends, and standard deviation, very commonly they ask is that it is the root mean square deviation, or it is the square root of the sum of the deviation square by n. So this is how we are calculating the standard deviation. And as I said that usually they don't ask the calculation of the standard deviation, but be ready for a simple silly question and where you have to apply the common sense. Okay, then what is the normal distribution pattern? That is again a very important section, very commonly asked. And here the point what you have to remember is it is a Gaussian curve, one thing. Now second is that it is a bell shaped or bilaterally symmetrical. In that way, that mean, median and mode are same. This is a very important point, that mean, median and mode are same in the symmetrical distribution, because in the asymmetrical it is having a different relationship. If it is a right skewed deviation, the mean is maximum followed by the median then the mode. If it is a left skewed deviation, then mode is maximum followed by the median or the mean. So remember this relationship. And if we are talking about the normal distribution pattern, the 50% of the values are above the mean value, 50% of the values are below the mean value. And then we are having that 68% of the values are covering within a mean plus minus of the one standard deviation, and 34% on the one side, 34 on the one side, and outside is 32. Please listen carefully and read the question carefully, where they're talking about within this range or outside this range. So within the range of plus minus of one standard deviation is 68%, and outside total is 32. And this 32 is further is half on the above the plus one and half is below the minus one. So they can make a question little bit complicated, and they can ask how much is the population of above the plus one standard deviation or how much is below the minus one standard deviation. So if we talk about separately, half of the 32% means the 16% is above plus 1, 16% is below minus 1. Within the plus minus of 1 standard deviation is 68, and outside the plus minus 1 is 32. Outside the plus 1 is 16, below the minus 1 is 16. So read the question very carefully. Clear? Now how much is within the plus minus of the 2 standard deviation is the 95%, and how much is the between plus minus of the 3 standard deviation is around 98 to 99. Some books they write 99, some books they write 98 also. Clear like that. Okay. So this is the basic framework of the questions what has been asked, that how much is the values within the range of the plus minus of 1 standard, 2 standard, 3 standard deviation. So we should be able to solve the basic numericals also. Clear? This is how the right and the left skewed deviation looks like. If the long tail is towards your right side, it means it is your right skewed, where the mean is maximum, because we see on the x-axis, no confusion. And if it is the long tail is going towards your left side, and then it is your left skewed deviation, where mode is maximum. Then what is your relative deviate? Relative means the deviation of a value from the mean value in terms of standard deviation. So x minus x bar by SD is your relative deviate. And what is your error? The error is depending upon the sample size, and its formula is the standard deviation by square root of the sample size. So more is the sample size, the lesser will be the standard error or the sample error of the mean. So these are a few important points about the dispersion. Now another is that we can make an error, and for any study we have to frame a null hypothesis. Null means that disease is not caused by this risk factor, or this factor is not causing the disease. Take for an example, if I say smoking is not causing the lung cancer, it is the null hypothesis. If null hypothesis is true, means smoking is not causing the lung cancer, and the true thing, if you are accepting, you are not making an error. But if the true thing you are rejecting and your study says no, the smoking is causing a lung cancer, obviously this is not a proper example which is fitting up. If I say the null hypothesis, another example, if I say that diabetes reduces the possibility of or exercise reduces the possibility of the diabetes. So this is my null hypothesis is exercise is not reducing the possibility of a null hypothesis. So again, this is actually not true. But if your study is showing that this is true, so if it is true and you are accepting, so you are not making an error. So just remember in a simple word that if your parents are giving you the advice, that's a true thing, but you are rejecting, you are making a major blunder of your life. So true thing, if you are rejecting, it is a type 1 error. So null hypothesis true, but your study says it is false, so you are rejecting the null hypothesis, it is a major blunder and it is a type 1 error. But if a null hypothesis is a false, you have to reject it, and then it is not an error. But if you are accepting a false thing, it is a type 2 error. As I said that smoking is not causing the lung cancer, this is a false, and you have to reject and you have to say no, no, smoking is causing the lung cancer. But if you are accepting this false hypothesis because your study is showing that smoking is not causing, you are making an error. So if a null hypothesis is actually in reality is false, but your study is showing it is true, you are accepting, it is your type 2 error. Clear? So just remember in short that if a null hypothesis is true, you have to accept, but if you are rejecting, it's a type 1 error. If a false thing, you have to reject, but you are accepting, your friend is advising something, it is wrong, you are accepting, it's a type 2 error. Clear? So the major error is a type 1 error, and it is more dangerous. So we have to keep our type 1 error at a lower level. So maximum permitted upper limit of the error is 5%, that is alpha, and our permitted upper error level of error is 5%, that is an alpha value. So obviously our error, that is a p value what is given for the type 1 error, should be less than 5% or less than 0.05. This is the point what they ask is. So the significant study is if our p value is less than 0.05 or our type 1 error is less than 5%, and if our error is less than 1% or the p value is less than 0.01, like we are making a less mistake in the exam, we are the topper of that exam, so our study is highly significant. Okay? So in the errors you have to remember the 3-4 points. The null hypothesis true rejected is type 1 error, false accepted is your type 2 error, maximum upper limit of type 1 error is 5%, so your p value should be less than 5% or 0.05 for significant study, and if your p value is less than 0.01, it is highly significant study. Okay? Now for the analysis of what test we will be using. Now it depends upon what a data is, whether it's a qualitative data or the quantitative data. So very commonly they give you a study that groups are there and what test you will be using. So please listen carefully. Now for identifying that which test we have to use, you have to look for the two important things. First is what type of the data it is, one thing. Second is how many groups we are comparing, whether we are comparing the two groups or we are comparing the more than two groups. Okay, so these are the two important points. Now the question is that how you can say whether it's a quantitative data or qualitative. कभी कभी तो पता चल जाता है, कभी कभी मुश्किल होता है. So if you can measure that data, or if they're talking about the average value, they're talking about the mean value, they're talking about the standard deviation, it means it is some calculation has been made and it is your quantitative data. Clear? But if they are talking about the percentage or the proportion, so it will be your qualitative data, because percentage में आप कोई calculation नहीं कर रहे हो, proportion में you are not making any calculation, you are simply saying that this percentage is this much, this percentage is this much. Clear? So in the qualitative data we are being expressed as a percentage, proportion, and the quantitative data we are talking about either the mean or the standard deviation. This is one thing. Now if we talk about the quantitative data, and then we have to look for that how many groups we are comparing. If we are comparing the two groups or more than two groups. If we are comparing the two groups, then we will be using the t-test or the student t-test. Clear? And if you are comparing the more than two groups in the quantitative data, it is the ANOVA test what we are using. Clear? Now one more important point is they ask that in these two groups, what these type of the two groups are, whether they are paired or unpaired. Now please understand carefully क्या difference है. Now paired means जैसे कहते हैं ना paired socks हम पहनते हैं, same चीज है. Paired earrings we are having, the paired hairpins we had, means it is a mirror image. The same thing should be appearing on the left and the right side. So if we are using the one group, parameters we had taken, and we had given some drug or some intervention had done, and after some time we are recording again the values. So this is the same individual, we had given some intervention, and one group before and another is after. So this is a paired, same group, before and after intervention. So two groups, same paired groups are there. Now you can understand like this. Suppose in a very simple way I say that I am recording your weight today, and I'm giving you the stress of the exam, and suppose after 1 month I'm recording again your weight. So some might lose the weight, some might gain the weight. So what is the weight before the 1 month of the exam, and what is the weight after the exam? So this is the two groups. So same individual we are comparing. So here we are using the paired student t-test, and if you are comparing the two different individuals or the two different groups, not the individual, two different groups we are comparing, then we are using the unpaired t-test. So starting first you have to identify whether this is a qualitative or quantitative, and if it is a quantitative, then two groups we are comparing or the more than two groups. If more than two groups, straightforward is an ANOVA test. And if you're comparing the two groups, then see that these two are the paired or the same before and after intervention, or the two different. And if the same before and after, we are using the paired t-test. And if it is the two different, we are using the unpaired t-test. Clear? And if it is the qualitative data, then if you are comparing the two same groups, then we are using a sign test. But if you are comparing the two different or more than two groups, then we are using a chi-square test. Okay, so this is the diagrammatic representation, and in a simple way you have to remember and look at the situation, look at the question, and then you have to think that what type of test we can use. Now for the chi-square test, one more point we have to remember, that they say that here the values are arranged in a tabulated form in the multiple rows in the column. So they say that we can calculate the degree of freedom also by the chi-square test, and it is calculated as the number of the columns minus 1 and number of the rows minus 1. Then how we can represent the distribution of the data? Either we can divide as a 100 equal parts by the 99 intersections as a centile distribution. And remember, at any percentile we say, suppose if I say the value is at 80th percentile, it means your value is at the 80th point, means the whatever the total individuals or total values are there, 80% of the values are below you and the 20% are above you. If your situation is at the 90th percentile, because many exams now they give the percentile value, they don't give the percentage, means whosoever has appeared in that exam, suppose your ranking is the 90th percentile, means the 90% of the students had the marks below you and the 10% are above. So remember one point, that percentile means utna percentage of the value are below you, that's all. So sometimes they can ask small numerical that how much is value below you, how much of the value above you. So read the very question very carefully, they are talking above or below. Clear? Or we can have a quartile distribution. Quartile means 4 equal parts. We had a distribution, and here the 3 intersections, so 25, 25, 25% is there, and again it is the midpoint is the second quartile, 50% below, 50% above. First quartile means the 25% below, 75 above. The third quartile means that 75 below, 25 above, like that. Then how we can have the sampling? Now sampling can be as a random sampling or non-random sampling. Obviously the preferred is a random sampling. Now in the random we can have the simple random like a lottery system, or we can have a selection in a systematic order. So first we'll calculate the sample interval, and then as per the sample interval we will collect the value, that is a systematic random. Or if we have to have a representation of the different features, then first we will distribute the data as per the different groups, and from that group we are having the simple random sampling. Like if I show you the images, so this is your systematic random sampling. Means suppose out of these individuals, out of these six individuals, if I have to select the two individuals, okay, so my sample interval is 1 is to 3, means every third candidate I have to select. So between the first three I'll be selecting the random. Suppose if I had selected this camp, we have to leave one, then second, then I have to go with the third, or we have to leave one second and I have to collect the third, like that. Okay, so this is your a systematic random sampling. Then what is the stratified random sampling? Stratified means first I'll make a four groups, and then from each group I'll be having the a simple a random sampling. जैसे कि I had given you one example. Suppose if I want to collect the population, or want to know that what is the education status of the community affecting the COVID vaccination intake. So, what I'll do, I'll make a groups of one group having the education of less than fifth class, another group I can make an education of the 5 to 12 class, the third group I can make a who are graduated, and the fourth I can say who are the postgraduate or postgraduate degree, and then I'll select from this population the 100 individuals. Suppose I want an equal representation, and then we'll see that among these 100 individuals how many are receiving the vaccination. Suppose if I come to know from the 100 which are selected from a the education class less than a 5 class or the fifth education standard, only the 20% had received the vaccination. Those who are having the education status between the fifth class to the 12th, the 50% of the community is vaccinated, and those who are having the graduation, 70% individuals are vaccinated, and those who are postgraduate, the 80% of the community is vaccinated. So it means the education is affecting the acceptance of the COVID vaccination, like that. So simple term, what we have to remember is a stratified means a strata. We're making the groups, and from the groups we are having the simple random sampling. And the cluster random sampling, what we have to remember, that it is used for the immunization survey, and where we are having the 13 to 7 clusters, the 30 clusters, and in each cluster we are having the 7 children. So the point to remember about this random sampling is that if they say which is the best sampling, the random is better over the non-random. The second, if they say that out of the random which is the best, then out of the random it is the stratified random sampling which is supposed to be the best type of the random sampling. And the next question, that which we are using in the immunization survey, it is the cluster random sampling. Or we can have the non-random sampling. The non-random sampling, like simply we can have the voluntary sampling who are coming into the study, or we can have the snowball sampling, whosoever is coming in contact we are taking into the study, or we can have the convenience sampling. So as per our convenience, whosoever is near us we can take, or whosoever is standing in the right row, the left row, the middle row we can take. And we can have the quota sampling, that we can take a group like more than 30 years, the less than 30 years, more than 60 years, so we can take them in the sampling. So this is all about your statistic. So okay, we'll take another 10 minutes break here, and then we'll discuss a few more topics. So if I say that the time by my watch is around 6:40 or 1, so we'll start our class at 6:55. Okay, so we'll start our class at 6:55. So now we'll be discussing a very important topic for your examination is healthcare system of India. Here we will be discussing that how our infrastructure is designed, what are the various health workers posted at the different health centers, what are the population coverage and how they are functioning, what are their important functions. Now, if we talk about the level of care, we are having the three tier system or the three level of care. Primary level care is being given till primary health center by the village workers, sub-center workers, and the primary health center workers. And the second level care is being given through the community health center and the district hospital. And the tertiary level care is being given by the medical college and super specialty hospital. Now, if a person is not being treated at the primary level care centers, means still PSC, the patient is being referred for the first time to the second level care centers, and second level care centers are also known as first referral centers. So no confusion, the second level care are the first referral centers, and if they are not being treated there, they are being referred for the second time to the tertiary level care centers. So the tertiary level care centers are also known as the second referral centers. Clear? Then we had the various elements of the primary healthcare, and you can remember as by the elements. Now, health education, local endemic disease prevention and control, essential drugs availability, the MCH care, immunization, the nutritional status, the treatment of the common diseases, and the safe water supply and sanitation. These are the elements, 8 elements of the primary health care. Now, what are the various principles of the primary health care? So, commonly asked question is all are the elements of the primary healthcare except all are the principles of the primary healthcare except the principles of primary healthcare is the equitable distribution. It should be equally distributed, no demarcation, no differentiation to the community. Community participation, the community should come forward to participate in the acceptance and spreading the knowledge to the other areas, intersectoral coordination and appropriate technology. So these are the principles of primary health care. Now, very important question asked is that how much is the population is being covered by the various health centers, and how many beds are available, which are the important workers posted in these health centers. Now, if we talk about the centers as the sub-center, PSC and the community health center, because the district hospital onwards, there is no population limitation. There is a one district hospital in each district. Okay, so the population covered in the plain and hilly areas are different. The reason is that there should be the minimum time required for a person to reach to the nearest hospital, and if this center is in the hilly area where the traveling time is more, so the center is covering the lesser population, and if it is a plain area, so the traveling time is less, so it can catch a larger population also. But remember one point, if they didn't mention about the plain or the hilly separately, then we have to go with the plain area. Okay, so the population coverage of the sub-center in the plain area 1 per 5,000, in the hilly area 1 per 3,000, in the primary health center 1 per 30,000 in plain area, 1 per 20,000 in the hilly area, community health center 1 per 1,20,000 in the plain area, 1 per 80,000 in the hilly area. Now, one more golden rule, if they had not given you the exact value, what is the nearest value, you have to go with that. And very commonly it is seen with the community health center, and in the community health center they simply write as the population coverage of the 1 lakh. So it is in between, or sometimes for the primary health center they write like a 25,000. So to the nearest value we have to go. Then what is the bed availability? Now, in the subcenter type A, which is also known as the non-MCH centers, means we cannot provide the MCH services. MCH is mother and the child health services, and the most important requirement is that we should conduct the delivery and we should have the hospital bed available for admission. So the type A subcenter are the non-MCH, means no beds, no deliveries are there. But the type B subcenters are having the minimum 2 beds. But if the workload is more, and what is the workload? If a number of the deliveries are more than 20 per month, then 4 beds are there. So if nothing has been mentioned about the number of the deliveries and they ask how many beds are available in the subcenter type B, then your answer should be the 2 beds are available. In the primary health center, then 6 beds are available. In the community health center, 30 beds are available. Then another important point is the staff members. They usually don't ask the number of the staff, but they usually ask which staff is posted. Now, if we talk about the sub center, the important staff is the multi-purpose worker, male and the female. If we talk about the primary health center, we had the medical officer and the health assistant. So, medical officer minimum requirement is a MBBS degree. Some of you might be after clearing your FMG exam may join your state medical services and become a medical officer. So the question is that what is the lowest center where the doctor is available? It is the primary health center, because below the primary health center, in the sub center or in the village, we had health workers only. Beyond primary health center, yes, we had a doctors available, and MBBS degree in the PSC, and in the community health center we are having the postgraduate degree doctors, that is a specialist available. And sub center is under the control of the central government, while primary health center and the community health center are being controlled by the state government. Then if we talk about the special workers posted in the village, and these are the grassroots level workers, the very four important workers are posted, and very commonly asked workers in the examination are the asha workers and the anganwadi workers from the village, and the multi-purpose workers from the sub-center. These are the three very important workers, and always a question has been asked from this section. Now the workers is the grassroots level is the traditional birth attendant or the asha workers. The full form is the accredited social health activist. Their counterpart in the urban area is the USHA worker or the urban social health activist. One point to remember, if they didn't differentiate between the ASHA and the USHA, sometimes they write as a urban ASHA is same as the USHA worker, and ASHA if they say it's a rural ASHA. Then we can have the village health guide and the Anganwadi workers. Now, if we compare their population coverage, where they are posted, and how much should be their educational qualification, who gives them the training, how much is the training duration. Now, the traditional birth attendant, village health guide, and the ASHA workers, they don't had their special centers, and they are working in the village from their home, while the Anganwadi workers, they are posted in the ICDS centers, integrated child developmental services providing centers, and these Anganwadi workers are the heart of these ICDS centers. Now if we talk about their population coverage, the TBA is a 1 per 1 village of the 1000 population. The village health guide is 1 per 1000. Now please listen carefully. Now currently we are having the 1 per 1000 population as an ASHA worker, and government is planning to have the 2 ASHA workers per 1000 population, but is still not implemented. So if a question is asked that what is the population coverage of the ASHA worker, your answer should be 1 per 1000. But in the urban ASHAs or the USHAs, they are covering the 1 per 1000 to 2500 population, and the Anganwadi workers in the plain area is 1 per 400 to 800, while in the hilly area is 1 per 300 to 800 population. To talk about their education, for the traditional birth attendant, no educational requirement is there, because simply they are trained guys to conduct the deliveries under supervision of the multi-purpose worker female. But for the village health guide, 6 pass, for the ASHA, the 10 pass, and for the Anganwadi workers, the 12 pass is there. The training duration for the TB is the 30 working days in 3 months. For the village health guide, the 3 months, in that duration they have to cover the 200 hours, and for the ASHA it is 23 days, and for the Anganwadi worker it is 4 months. Now they are being obviously trained by the senior person. The traditional birth attendant, they are being trained by the multi-purpose worker, a female, health assistant female, or the medical officer. The village health guide, they are trained by the medical officer. The ASHAs are being trained by the Anganwadi workers, multi-purpose worker female, health assistant female, or the medical officer, while the Anganwadi workers, they are being trained by the Mukhya Sevikas, and one Mukhya Sevika is training the 25 Anganwadi workers, and this Mukhya Sevikas in turn are trained by the Community Developmental Project Officer. So, one Community Developmental Project Officer is training the 4 Mukhya Sevikas, or indirectly it is training the 100 Anganwadi workers. Then this is the image. If I say that how these ASHA workers are functioning, because we know that a very important function of these ASHA workers are, she's a part of Janani Suraksha Yojana. Janani Suraksha Yojana means they are carrying or accompanying a pregnant woman at the time of the delivery, taking this lady to the hospital, getting this patient admitted in the hospital, staying with the patient in the hospital. So patient is having a feeling that some worker is with me, I'll be getting a good care in the hospital. And this is promoting the hospital delivery to reduce the maternal and the child mortality. So this was the activity started under a very important national program, National Rural Health Mission, as the Janani Suraksha Yojana. And ASHA workers are also responsible for the various health educational activities also. In some states, they are being given a pink sari, so they are also called as a pink sari wali didi aa gayi, ASHA didi aa gayi. So we have to remember the functions of the ASHA workers. The very important point that she's a part of which national program? She's a part of National Health Mission. Now please listen carefully. If they ask that ASHA is a part of National Rural Health Mission or the Urban Health Mission, then your answer should be the Rural Health Mission. But if they simply ask the ASHA is a part of which program, then your answer should be the National Health Mission. Because if they give you the options like a National Health Mission, the tuberculosis program, the leprosy program, or the HIV program, then your answer should be the Health Mission. Because this program was started first as a rural health mission in the 2005, and ASHA was the main worker of this program. And when we had seen the success in the rural areas, then its counterpart was started in 2013 as a National Urban Health Mission, and the name given to the urban ASHA was the USHA worker. And in the 2013, these two branches were combined together, and we had a common program as the National Health Mission had the two divisions. One is the rural areas, another is in the urban areas. Okay. Then what are the selection criteria of a ASHA worker? Means who can be recruited as ASHA? She should be female in the age group of 25 to 45 years, because we want an active, energetic female. She should be resident of the same village. That is very important, because in the night also she is available to take a pregnant woman to the hospital. Because if a lady is residing in another village, then transport is a major issue in a night. So how that Asha will come from another village to this village? So she should be the resident of the same village. She should have the good communication skill. Otherwise, she will not be able to convince the community, motivate the community. She should be 10th pass, and preferred is the married, divorcee, or the widow, because she will be in the same village. If you are selecting the unmarried girl, giving them the training, after the marriage she is going to another village, so our training will be wasted. So we will prefer the married woman or the divorcee or the widow. Now what are the important functions of these ASHA workers? Now she is a part of Janani Suraksha Yojana. That was a activity for promotion of the hospital delivery. This is the first most important function for which this program was started and this worker was designed. But as later on, we had seen that ASHA workers are free, because every time the delivery is not being conducted, so they had been assigned some other functions also. She is responsible for home delivery of the contraception, like a condom, emergency contraceptive pills, or oral pills. Then not the IUCDs. She can deliver, but who is going to insert? So there is no purpose of delivering IUCD at home. She is also acting as a DOTS agent, means in relation to the tuberculosis program. They can give the medicine in the intensive phase of the tubercular treatment. And she is also responsible for giving the treatment for the common problems like diarrhea, fever. So she can distribute the ORS packet, the paracetamol tablet, cough syrups, antibiotics. And they are also distributing the iron folic acid tablets to the pregnant and lactating women. And as we'd already discussed, that she is a worker of active surveillance in the active case finding of tuberculosis, leprosy, filariasis, leishmaniasis, because these are the diseases which we want to do their elimination. But remember, not the malaria, because the main worker of active malaria surveillance is multi-purpose worker male. Then they are giving the home-based newborn care, and this is the question asked, that how many visits she is giving. If it is the home delivery, then the number of the visits are 7 on the day 1, 3, 7, 14, 21, 28, and 42. If it is the hospital vaginal delivery, because patient is being discharged after 48 hours, so the home visit starts from the day 3, 6 visits are there. And if it is a cesarean hospital delivery, then usually patient is discharged after 5 days, so the home visit starts after the 7 days. So 5 visits in the cesarean section delivery, the 6 in the hospital normal vaginal delivery, 7 is in the home delivery. Okay, now she is a member of the village health sanitation and the nutrition committee, and that's why she is affiliated to the gram panchayat, and she supervises the construction of the household toilets. And no confusion, she is not constructing because she is not a labor, but she is supervising because she is related to the health sector. But Asha never conducts the delivery. Remember this point, okay? So if a question is asked that who is conducting the delivery, the main worker is multi-purpose worker female in the periphery. She can take in help of her TBAs in the village, but she should present in each and every delivery. Then we are having the Panchayat Raj system, as we all know that in the district it is the Jila Panchayat, Panchayat Samiti at the block level, and the Gram Panchayat at the village level. Then she is also responsible for the health education and mobilizing the village community to the ICDS centers, because where every month we are having the nutrition day camp. So they are communicating or they are educating the people of that particular village that every month they should go to these ICDS centers on the nutrition day. So either the children are being checked and the mothers are being given a health education. Now, the important worker posted in the ICDS center, this is the logo of an ICDS center where the mother with the baby sitting in the womb, and these are the functions of Anganwadi workers. Now, Anganwadi workers are giving the non-formal school education. They are measuring the, like in this image, the mid-arm circumference means responsible for the growth monitoring. They are also giving the vaccination, immunization, and they are also distributing the midday meal. So if we talk about the Anganwadi centers, the beneficiaries, you can remember like children 0 to 6 years, their mothers and their bodyguards, what we always discuss in our classes. So the main beneficiary is the 0 to 6 year children. As they are small, they cannot go alone. So their mothers are also going. And in the village, the daughter-in-law Bahu is not going alone. Some bodyguard is going with them, and that bodyguard is either the adolescent unmarried girl in the age group of 10 to 19, that is adolescent age, or the other reproductive age group female, the age group is 15 to 49 years. And the functions of these Anganwadi workers is the immunization to the baby and the mother, the growth monitoring, the nutritional supplementation in the form of midday meal. And here the question is that what is the composition of the food? It is having the half of the protein and 1/3 of the required calorie of that particular age. Then they are examining, and if you find any baby is sick, they are referring the baby to the higher centers and giving a non-formal school education to the children, because in the village the child is getting admission at the age of 6 plus in the school. Unlike in the cities where we are sending our children to the playgroup to the nursery, but in the village they are going directly to the school. So below 6 years they are being given a non-formal school education in the ICDS centers, as well as the health education to the mother. So these are the important functions of Anganwadi workers. And we all know that TBAs, they are conducting the deliveries under supervision of multipurpose workers, and the village health guide, they are like a guide in educating the people in the village. Then we had an important worker in the sub center is the multi-purpose worker female and male. Now, multi-purpose worker female are mainly concerned with the MCH activity. So they are doing their examination, BP monitoring, antenatal checkup, conducting the deliveries. After the delivery also, they are visiting the houses, giving the postnatal care also, and giving the vaccination to the babies also, giving the vaccination to the mothers also. So multi-purpose workers, they are doing the multiple functions. And we are having the multi-purpose worker male also. So if we talk about the function of the multi-purpose worker female, they are responsible for the antenatal and the postnatal visits, MCH care, conducting the deliveries. They are maintaining the eligible couple register. And so this is another question they asked, that at what center the eligible couple register is being maintained. It is being maintained at the sub center by a multi-purpose worker female. And we know that eligible couple are where the age of the wife is between 15 to 49 years. She can insert the ICD. So this is another question, that what is the lowest center where ICD can be inserted is the sub-center by multi-purpose worker female. And she is also responsible for giving the health education, the contraceptive advices, and she is identifying the patient who wants an MTP or the tubal ligation and referring to the higher center. So remember that MTP is not conducted at the subcenter, it is lowest conducted from the PSC onwards. But if any person says that Sister D, want my medical termination or MTP, then she can refer that lady to the primary health center. And she's also responsible for training of junior staff like an ASHA worker, TBS, record maintenance, and immunization. Now, what are the functions of multi-purpose worker male? Now, multi-purpose worker male, it is again a very, very important worker, and it is responsible for immunization. It is responsible for chlorination of the well water. It is responsible for active malaria surveillance. It is responsible for the IMNCI activity. And what an IMNCI activity is, that it is the integrated management of the neonatal and childhood illnesses. It means that they are being trained to examine the baby, and based on the clinical symptoms they are categorizing the patients into the three categories, because at the subcenter we don't have too much of the investigation facilities are there, and based on the clinical symptoms they are categorizing the babies either into the green category or in the yellow category or the pink category. Now green means that these are the ambulatory patients, the home based patients, the very easily they can be treated. Now yellow are the borderline cases, we are giving them the treatment but doing their follow up, and if they are not improving then we are referring to them to higher centers. Or it could be the pink category, the alarming urgent category, pre-referral treatment is being given and they are being referred to the higher centers. So this is an IMNC activity, the function of multi-purpose worker male. So they are responsible for the active malaria surveillance, they are responsible for giving the all sort of vaccination, they are sitting at the sub-center, they are examining all the patients who are coming and they are treating. So they are actually the doctor of a sub-center. Doctor, anybody if it is coming to the sub-center and they say doctor, doctor means they are talking about the multi-purpose worker male. And he is also responsible for giving the chlorination, doing the chlorination of water bodies or the well there in that area, IMNCA activity. And he is also filling a form under the IDSP project. Now IDSP project means it's an integrated disease surveillance project. Every week they have to send the report to the district hospital, means it is going via the primary health center, community health center to the district hospital, and within the last week, and we have to report that how many cases of the different symptoms has been appeared. So if we see that suddenly cases are increasing of a particular disease, then it means it is an indication of an upcoming epidemic and action can be taken. So here the form which is filled at the subcenter is the S is the subcenter suspicious form. It is going to the primary health center. P is the PSC and it is the probable form, and it is going to the community health center, and that is a L form, lab confirmed form. Okay, and in this way the information is reaching to the district hospital every week. And they are also responsible for the contraceptive distribution, health education, and the record maintenance. Then we are having the worker as health assistant. Now health assistant, we had male and female. They are posted at the primary health center, and they are visiting each sub center every week. So it means we had 30,000 population of the primary health center. Population of the sub-center is 5,000, means roughly the 6 sub-centers are under control of one primary health center. So once in a week they are going to these sub-centers. They are supervising the function of multi-purpose workers there. Obviously the male health assistant will supervise the function of the multi-purpose worker male, and the female health assistant will supervise the function of the multi-purpose worker female. So they are visiting every week, supervising their functions. And one important point is that randomly they are also visiting the houses minimum 10%. population, to ask whether the multi-purpose workers are coming or not, they are giving their services or not. Okay. And in addition, the multi-purpose worker female, under the supervision of the health assistant female, they are organizing the meetings with the local NGOs for health promotional activities. Clear? So these are the important functions. And one more point we have to remember here is that we had discussed like population of various health centers. So sometimes they ask indirectly what is the population coverage of these health workers. So remember one golden rule, that health worker, in what center they are posted and what is the population coverage of that center will be the population coverage of that worker. Like take for an example, if I say they ask what is the population coverage of the multi-purpose worker, we know that one male or one female is posted at the sub-center. And what is the population of the sub-center? It is 5,000. So indirectly, how much is the population covered by multi-purpose worker, male or female, is the 5,000. So simple, no rocket science. Same like if they ask what is the population coverage of the health assistant. Now where health assistant are posted? They are posted at the primary health center. What is the population coverage of primary health center? Is the 30,000. So indirectly the population coverage of the health assistant is also 30,000, like that. Okay. Then we are having the specialist, means the postgraduate doctors at the community health center. And in general what we have to remember is that we are having the specialists like a surgeon, obstetrician, anesthetic there. So the question is asked that where we can do the major surgeries under the spinal anesthesia, general anesthesia, the regional anesthesia, from the community health center onwards. So the lowest center where you can conduct the cesarean section, you can have the cholecystectomy, appendicectomy, laparotomy, is the community health center. But at the primary health center, medical officer is there, and the medical officer can perform the surgeries under the local anesthesia. So any abscess drainage, yeah, any repair of the episiotomy wound, we can conduct at primary health center. So here the question to remember is that they ask that primary gravida where should deliver. Primary gravida we should deliver from the primary health center onwards, because she requires episiotomy, while multi can be delivered from the sub-center onwards, because multis, they didn't require usually the episiotomy, so they can be delivered at sub-center. But suppose if they say that primary with severe anemia, or primary with a breech presentation, or with a preeclampsia or gestational diabetes, should be preferred at to deliver at a higher center where we can perform the cesarean sections, or we had a facility to manage the patient or the baby in the ICU, means from the district hospital onwards, and the medical college or the super specialty hospital. So like that you have to see that what they are asking and at what center you can get the delivery done. Okay. And one more point we have to remember about the specialists. In general, they ask that population coverage of the specialists is 1 per 1 lakh, because they are posted in the community health center, except is the ophthalmologist. It is covering 1 per 5 lakh population, because it is as per the protocol of the Vision 2020. We'll discuss separately under the National Program for Control of blindness and visual impairment, where the ophthalmologists are posted from the secondary vision center or the service center onwards, and it is covering the 5 lakh population. The primary vision center is covering the 50,000, where we had a paramedical ophthalmic assistant, and the secondary vision center or the service center is covering the 5 lakh population. Tertiary vision is the 50 lakh, and we had a center of excellence is the 5 crore, and the apex center is covering the whole country. So we are having the ophthalmologists from this level onwards as the secondary vision center, so they are covering the 5 lakh population. Clear? So we don't have the ophthalmologist in each and every community health center. If it is an upgraded community health center covering the larger population, or we can have the one ophthalmologist in who is giving the services to the 2-3 nearby community health centers. Clear? Now another point is that what is the suggested norm, means for how much population we should have the one worker, and how much is the current situation. Now if we talk about the suggested norms of the Indian public health standards, the doctor requirement is 1 per 1000 population, but currently we are having 0.7 per 1000 population. The nurses we had 3 per 1,000 is a recommendation, but we are having 1.7 per 1,000. Now beds we are having currently zero point 0.9 per 1,000, recommended is 1 per 1,000. As I said that currently ashas are 1 per 1,000, but recommended are 2 per 1,000. Clear? So no confusion. Now multi-purpose worker, female and male, as I said that recommended is 1 per 5,000. Yes, we had fulfilled the criteria. Health assistant, male and female, recommended is 1 per 30,000. We had fulfilled because we had one at the primary health centers. We had already discussed this point. Now pharmacist 1 and the lab technician 1 per 10,000 are recommended, and yes, we are able to fulfill this requirement. And TBAs and the village health guide 1 per 1,000. Yes, currently we are having 1 per 1,000. And Anganwadi workers 1 per 400 to 800. Yes, we are having in the plain areas. Now there is a little bit difference in the population coverage in the urban areas. As I said that we can have better transportation, the better roads, so larger area it can cover. So in the urban structure, if I say that sub centers are being replaced by the health and wellness centers, and here we are having the auxiliary nurse midwives, ANMs, but now the ANM has been replaced by the multi-purpose workers, female. So earlier name was the ANM, but now we say it's a multi-purpose worker, female. And their activity, what we say, it's Anmol. Anmol means ANM online. Now they are being divided, had been given the tablets or iPads, so they can have the online registration of all the activities. It is saving their time. So that's why they say Anmol is the activity, means ANM online. Okay, and they are covering the population of 10,000. The rural areas my subcenter is covering the 5,000, and urban subcenters or the health and wellness centers, they are covering the 10,000 population. Now the urban PSCs, it is parallel to the rural PSC. Rural PSC was covering the 30,000. Urban PSC is covering the 50,000 population. Urban CSCs in the metro cities, it is 1 per 5 lakh, and the non-metro it is 1 per 2.5. As in the rural CSCs, it is covering 1 per 1 lakh population. And then we had a medical college. So this is your urban infrastructure. So this was all about your healthcare system of India. Now we can have 2-3 more points about the another activity, and that is how we are managing in the disaster. Now if I say that disaster management is not actually a role of a medical officer in toto, means we take the help of many other departments also, and the medical department is one of them to treat the diseases or some adverse ill health. Okay, so we are having the one authority, that is a National Disaster Management Authority with this logo, and you could see that there is a map of India, in the center, covered with a tricolor flag and all the hands joining together. It means that different branches or the different people of the different areas, they are helping the people who are affected in the disaster areas. Okay, so ministry controlling is the disaster activity is the Home Ministry, and the Prime Minister is the chairman of this National Disaster Management Authority, and we are having the head office in Delhi. Now, very important point, we have to understand this disaster cycle. Now, disaster cycle means whenever we had an impact, and we have to give the response to the affected individual. So here the question is that who is giving the first response? It is coming from the local people of that area, and they inform to the authority that some mishappening is there, and then the team is coming from the higher center. The nodal center for controlling all these disaster help or the disaster management is the district. Earlier it used to be the center, but it was taking time for the information or the guidelines to come from the center. So now the government has given the authority to the district magistrate. So the nodal center for the district this disaster management is the district. Okay, then following the response, we have to do their rehabilitation in the later time, and these two steps are the post disaster. After the disaster only we can give the response and doing their rehabilitation. And only the role of the medical officer or the doctor at this step, that how we are giving them the response. And here the question is that what is the triage and the tagging, and what are the diseases common, and how we can treat or avoid those diseases. Then if it is a man-made disaster, then we have to think that why this disaster has happened. So we are doing the mitigation means trying to find out the cause. And if it is a natural disaster, then we cannot do anything. We have to prepare ourselves to face for the next impact of the disaster. So the mitigation and the preparedness are the pre-disaster phases. So this is the question asked, that what are the pre-disaster phases, what are the post-disaster phases. Now coming to the response, and here role comes is for the triage and tagging. Now triage means workers are trained to differentiate the patients or the individuals depending upon their chances of the survival with the available treatment. Now here the differentiation is not done based on the severity of the illness, okay, because they had to be shifted to the nearest hospital, and in the nearest hospital whatever the best possible services are available, how many lives we can save. So this is the triage system, and we are categorizing the patients into the four categories. Although this is triage, but we are having the four tags or the four color categories are there. So remember in the triage that a segregation of the patients not on the basis of their severity of the illness, but on the basis of their chances of survival with the best available treatment. Clear? And here the question is that what are the four categories, which is the high risk categories, which is the lowest risk category. The red is the high priority group, and followed by the yellow, green, and the black. So always we had the traffic color of a traffic light, like colors of the traffic light, that red, yellow, green, and additional is the black. Then red is the high risk category, where the life-saving surgeries or the resuscitation is to be done within the first 6 hours. Yellow is the medium risk categories, where the life-saving surgeries can be extended or they can be delayed up to the 6 to 24 hours. The green is an ambulatory low risk category, and the black is the least risk category, the dead patients or the dead individuals, so the moribund patients. Okay, so these are the four categories of the triage system. Then the question is that what are the diseases reported in the post-disaster phase? The most common is the gastroenteritis, and other could be the acute respiratory tract infections, leptospirosis, rickettsiosis. And the next question is that what is the first step, because it is the gastroenteritis which is related to the unhealthy water. So we cannot rebuild our water purification plant in that area which has been destroyed by the flood or by the earthquake. So what we can do, that we have to make the safe drinking water available in that area, and this is only by doing the chlorination. So we are doing the chlorination of our water source, collecting the water in the tank, putting the chlorine tablet or the bleaching powder, doing the chlorination. And the important point is, because there is a risk of repeated contamination, so we are leaving the free residual chlorine above the normal level. Now the normal level is 0.5 ppm after the contact of the 1 hour, but here we are keeping 0.7 or above. And free residual chlorine level in the swimming pool, it is 1 ppm or above. These are the questions has been asked. Okay, then what is the role of a vaccination? Now as we know that gastrointestinal infections either could be because of the typhoid, because of the cholera, hepatitis A, and all can be prevented by the vaccination. So the question is, can we give the vaccine following the disaster? But the answer is no. Why? Because if we are giving the vaccine, it will take some time to develop the antibodies. But the incubation period of the cholera is short, so the disease can happen earlier. So there is no role of the vaccination of the typhoid, cholera, or the tetanus or the hepatitis A in that area, except the measles. Because they say that why the measles can happen and how we can prevent. Because following the disaster, the whole community is moving to the relief camps, and there is an overcrowding. So if our children less than 5 years are there, overcrowded, and if one child is having the infection, it can transmit the infection to others. And we know that if within the 3 days of an exposure we are giving the measles vaccine, within the next 7 days it can produce good amount of antibodies, and the measles incubation period is 10 to 14 days. Means on the day 10th a child develops the upper respiratory tract manifestation like an cough, coryza, conjunctivitis, and the day 14 the rash appears. So before day 10 the good amount of antibodies can be seen in the circulation of a child if vaccine is given within the first 3 days. So measles is the only vaccine, if we find that children are there in a higher number in a crowded place, yes, we can give the measles a vaccine. So these are the a few important points about the disaster. Then another short condition what we can discuss is the biomedical waste disposal. And we know that the waste which is generated in the hospital is infectious. So we should be disposing that waste in a safer way, so it is not contaminating or it is not affecting the health of workers. So how we are disposing the biomedical waste? Now biomedical waste disposal is controlled by Central Pollution Control Board, which is working under the Ministry of the Environment and the Forest, which is also controlling the air pollution. Now we are having the four important categories, and you could see these type of the posters in the hospitals where they are mentioning the four categories. As like in a yellow category the sister is dropping the cotton gauze pieces soaked with the blood. In the red category they are dropping the gloves. In the white category the needle is being dropped, and the black category it's a domestic waste, but we had an additional blue category also for their glass items. So uh, these are the different categories, and one important point is you could see that there is logo on these containers or the plastic bags. We can also have these logos on the trolleys or vehicle which is transporting this waste. So this is the logo of the biomedical waste. So by looking this logo, it is clear that the material which is in this bag or in this trolley or in this vehicle is infectious. Or we can have this logo of the radiation hazards. This we can find after the in the hospitals and the outside the X-ray room, outer the CT or the MRI room. So this is suggestive of the radiation hazards, and that's why it is written that pregnant woman is not allowed in this area. Okay, now the question is that what are the waste coming into the yellow, red, white and the blue category? This is very commonly they ask. So the content which is going into the yellow category is the infectious non-recyclable waste, and these are the plastic bags, containers, and directly we are sending them for incineration. We can have the human anatomical waste, very commonly asked. The placenta goes in which category? Animal anatomical waste, the soil waste, cotton gauze pieces, expired or the discarded medicine, cytotoxic drugs. The chemical waste, a solid chemical waste is going, because the liquid chemical waste is not being collected in any container. It is disinfected and directly disposed of into the domestic drain. And discarded bedding, linen, or other contaminated material with the blood or the body fluids. As well as we are also discarding the microbial waste and the empty plastic blood bag. It is also going into the yellow category. Now the red content or the red bag is used for the infectious, but it is plastic recyclable. You can remember like I say yellow means पीला पस, पस है जिसमें नॉन रिसाइक्लेबल है. Red lal lachila is the soft plastic material. It is being collected in the red category or the red bags containers, because all the plastic items like gloves, drip sets, cannula, and not the empty blood plastic bag, that is going into the yellow category. Then the white, we are collecting the infectious sharp waste, and that is actually the puncture proof containers. Like the material should not come outside. If you are collecting in a plastic bag, so the knife, needle can puncture. So these are the puncture proof containers, and collecting the sharp items like a knife, blade, scalpel or the needle. And one more point, if the needle is having the fixed needle with the syringe, then it is going into a white. Although it's a syringe is plastic, but if it is needle is fixed, then we give a priority to the needle going into the white category. And the blue, it is again a puncture proof containers, and we are collecting the glass item, either the discarded or the broken, or any replaced body implants. Okay. Then how we are disposing of this material? Then a very important method is the incineration burning, and this is done for content of the yellow bag. So very commonly they ask that yellow bag content are disposed of by which? It is the incinerators, or the incinerator is used for disposal of which category waste? It is a yellow waste. So incinerator is nothing but it is the burning of the content at a very high temperature, and it is around 1050 to 1200 degrees centigrade. No pre-treatment of the disinfection is required. Directly the bag is kept in the incinerator or the furnaces, except the microbial waste or the liquid chemical waste. As I said that the liquid chemical waste, no, even a collection bag is there, and disinfected by usually the 1% sodium hypochlorite solution or any other disinfectant material disposed of in the domestic waste. And the microbial waste first is being disinfected, usually by the autoclave or by microwave or by the chemical, and being disposed in the incinerators later on. Okay, so pre treatment or the disinfection is required for the microbial waste and the liquid chemical waste. Then how we are disposing the content of a red, a blue, or a white? Because here we are requiring their pre-treatment of the disinfection, and then we are breaking them into the smaller pieces, that is the shredding and the mutilation. And if it is the red bag content, plastic material, then usually we are converting this plastic into the coal tar, which is used for road making, or we can have the recycling. Rarely we are having the landfilling, but the white and the blue we are having the recycling mainly because the metallic items are there, or we can have the landfilling. But if we are doing the landfilling, then it should be the secured. Secured means that it should not contaminate the underground groundwater, and otherwise it will contaminate the underground water. And if you are taking this water through the well which is situated nearby, infection can spread. So we are having the secured landfilling, like we had an OTP while doing a transaction, because it should be secured. Nobody should access that transaction. So secured landfilling can be done either by inertization or encapsulation. Inertization, we are mixing the waste with the lime and the cement, or in the encapsulation we are putting the waste in a bag with some immobilizing agent, and just making it sealed from the outside, so nothing should come outside. So this is how we are disposing the content of a white category or the blue category. Then we are having the another instrument, as is the screw feeder, because we know that sharp item, if we had to do the shredding and mutilation, then they can injure the person who is handling. So what we do here, this is rotating like an rotatory auger, and we are putting the sharp waste in this, and this is rotating, and it is having a high temperature. So with a high temperature but no burning, it is causing the disinfection, and with the movement it is breaking the material into the smaller pieces also. So basically this screw feeder, it is used for the sharp infectious waste. So it is reducing the volume also, it is reducing the this weight content also, and that's why further it is easily disposed of. So remember, the screw feeder, it is used for sharp infectious waste. So these are the a few important points about biomedical waste disposal. So at this point we are closing the session here, and the remaining section we'll have in another session. Okay, so bye bye, good night, take care.